Good morning, everybody. We're going to be starting in about 2 minutes. All right, it's 8:45 and we're going to start. This is the 6th annual MS Patient Education Day run by the MS Center here at Georgetown University Hospital and Georgetown University Medical Center. Really want to welcome all of you for getting up early and attending our virtual patient education day. This is our 6th one, our second one, which is virtual. We have a lot of great content and things today. Really hope you enjoy the morning and appreciate your getting up early with us. I see a lot of friends in the attendee list, so welcome to everybody. If you wouldn't mind going to the next slide, Bethany. Okay, so this is our MS Center, and you can see it is a very robust center. There are actually 4 people that are not on this slide, so we have over 25 individuals at the MS Center. We are the largest MS Center in the Mid-Atlantic. We are a comprehensive MS Center as well as designated by the National MS Society. And as you can see, it is a very diverse group. We do clinical trial work, do a lot of education. Obviously, we do a great deal of patient care. A lot of people behind the scenes that whose name you might know, but whose face you may not be familiar with, that do a lot of the prior authorizations and take the phone calls and really keep the MS Center running. So special shout out though to Bethany Schreiber, who's on the top row, second from the left, who put together the MS Patient Day along with an outside vendor who created the website for us. So enormous amount of hours spent on this. And also special thanks to Dr. Shin, the medical director of the MS Center, who with Bethany was instrumental in figuring out the content of the day, but also getting us to this point this morning. So it took a lot of work to get here, as you can imagine. And Bethany and Dr. Shin deserve a lot of credit, but the rest of the MS Center is back there to support them. Next slide. This is our website. It is live anytime, so you can go to neurology.georgetown.edu/MS Center. We'll put that into the chat later on if you don't have it. But this is where you can keep up with what's going on at our center. We have updates on things like our recommendations for COVID vaccination, that sort of stuff. It has our bios, it has active research projects that we're doing. So it's a great resource if you want to keep up with what's happening at our center. Next slide. These are our sponsors. Running a patient education day is not free, and it requires a tremendous amount of support, financial as well as manpower and woman power. And so these are our sponsors. We really want to thank them very deeply for generously donating and allowing us to put this together. On the website, you will see that there are tabs that have sites or links to a lot of the sponsors. So please, during the break, visit their sites, and you can learn more about what they're doing, their pipeline as far as medications and their current medications. We have also our partners at the National MS Center and the NAA MS Registry. So all of these you can link to from the website where you linked into the into this Zoom. Okay, thank you again. Next slide. On the resource tab, you will be brought in, and there are a number of things that you'll be able to see. There's some online resources, which I think you'll find interesting. There will be a discussion this morning about NMO, neuromyelitis optica, and there are two foundations, the Samaria Foundation and the Guthrie-Jackson Foundation, where you can link to and learn more about NMO. I see that there are actually some attendees who have an NMO that are watching, so they may find that very useful. But even if you don't have NMO, I think you may find it quite interesting. And then there's a nonprofit organization called Eat MS, and that was created to be a reliable food supplier to all MS patients and caregivers. And so there's a nice link to their site. So by all means, take a look at that. There are also downloadable resources that you'll be able to go to. Eat MS has an overview and Living with MS, so you can actually download it and just read it at your leisure. Next slide. Dr. Amjad will be talking more about this, but we do have on our website the MS 101 webinar series. And again, this is, I don't want to steal Dr. Amjad's thunder, but it is a wonderful, wonderful resource that I would encourage all of you to go to our website and then take a look at the videos that are posted there. And these are educational videos, but Dr. Amjad is going to give more information about that later on, but it's a tremendous, tremendous resource. Next slide. So here's our agenda. After my introduction this morning, I will hand the baton off to Dr. Shin, who is the medical director of the MS Center. And then we will have a series of lectures. Dr. Osborne will be talking about a number of demyelinating disorders. In addition to multiple sclerosis, he will be talking about NMO, neuromyelitis optica, and MOG, myelin-associated glycoprotein. And these are very interesting, related but distinct diseases. Then Dr. Shin will talk about race, sex, and MS, really a very hot topic over the past 3 years. There will be a break, and during the break, videos will run. And so I would encourage you to watch the videos, or you can take a look at the resources at the site where you came into. Then David Pisval will give a clinical trial update. We have quite a number of clinical trials running currently. Some are closed, but there are a number of exciting ones that really are investigating novel medications that we think will probably come to market in the next 2 or 3 years. Dr. Amjad is going to talk about MS 101, our educational video content. And then Jeff Wilkin, who is a neuropsychologist, is going to talk about cognition in MS. And this is a very, very important topic, since we know that 60 to 70% of people with MS may have cognitive issues. They may be subtle and sometimes not so subtle. And then Deb Riley is going to, once again this year, do dance and movement at the back end of the morning. Always wonderful, really appreciate Deb's energy. She's just awesome. Then we'll have our last break. Again, there will be a video that will run during that. And then Kim Foster will close us out with a talk on support for loved one and caregivers. For those of you who don't know Kim, she is our licensed social worker and a counselor. In the department, she is just wonderful. She's been with us for just under a year and has really changed the character of what we do at the MS Center. We will have a Q&A, session at the end. And so please put your questions in the Q&A box. There's a chat box, but I don't use that. The chat box is just for all of us to communicate with one another. But if you have questions about any of the content, just put them in there. And then at the end, both Dr. Shin and Bethany will go through the questions and then pose them to the panelists. And then we'll have some closing remarks, and then that will be it. So a full morning, lots of great content. Again, a lot of work has gone in to prepare all of this, and we really hope you'll enjoy the morning. Next slide. And again, yes, use the Q&A box to ask any questions. And then again, we will get to as many of the questions as we can at the end of the program. Okay, next slide. Okay, with that, I am going to hand off the baton to Dr. Shin, who will be the Master of Ceremonies and will be introducing each of the speakers this morning. So Dr. Shin, the floor is all yours.
All right, thank you, Dr. T. I just want to add my welcome to everyone who's joining us. This is our 6th annual Patient Education Day, but unfortunately, due to the pandemic, the second year, as Dr. T said, that we have to do this virtually. So I'm going to ask all of you to try to bear with us. You know, doing these technical types of virtual programs is always tricky. I want to re-emphasize that as we do these presentations, if you have questions, you can enter them into the Q&A section. We won't be able to really answer them in real time, but at the end of our program, we are going to go through the questions and answer as many as we can. There have been some other questions already, just little technical things. I'm going to make a comment. As you'll notice, we don't have closed captioning. We didn't have the ability to do that. However, a transcript of this entire session will be available, as will saved files for each talk after this program. So for those of you who would benefit from that, you will have access to a transcript afterward. Some people are asking questions about maximizing the screen, and that'll be something you'll have to do on your own computer. The exhibit hall, I do want to emphasize this, our sponsors have live links. Now I'm going to say don't click on them in the middle of our awesome talks, but during the breaks or in between when you get a chance, you should be able to visit our different sponsors' websites or links, and I encourage you to do so. Okay, so getting started with our program today, our first speaker is Dr. Ben Osborne, who's Associate Professor of Neurology and Ophthalmology here at Georgetown, and he directs the Neuro-Ophthalmology Clinic as well as the Neuromyelitis Optica clinic. And that's really the topic he's going to focus on today. For personal reasons, he's not able to present live, but he has put together a pre-recorded video, which Bethany will project for us. So again, Q&A, you can still enter them. He won't be here to answer them specifically, but we can try to address any questions that you might have for him. So Bethany, I'll let you take it away.
Welcome everybody to the 6th Annual Patient Education Day. I'd like to thank you all for joining us again. I especially like to thank Bethany Schreiber for helping to organize this every year. She's done a great job of making sure that we've had excellent programs. Even during COVID, when we can't meet in person, we've fortunately been able to do virtual teaching like this. I've been invited to give a talk today about MS, NMO, and MOG. Most of you, I'm sure, have heard of MS. Many of you might have heard of NMO, and I imagine most of you have not heard of MOG. Even if you have, you probably don't know much about it. So I'm hoping by the end of today's talk, you'll have a better idea of what these 3 different diseases are. My goal today is to review the definitions of NMO, MS, and MOG, and try to highlight through some different cases the differences between these 3 diseases. Initially, we used to group all these patients together under the rubric of multiple sclerosis, but we now understand it's really important to differentiate which patients have which disease, as they have different prognosis and treatment options. And we'll discuss a little bit about those different treatment options toward the end of the talk. Multiple sclerosis, I'm sure you're all aware, is an autoimmune disease that affects the central nervous system. The central nervous system is made up of the optic nerve, the brain, and the spinal cord. And MS typically causes symptoms through relapses. So for example, optic neuritis, where you could have painful vision loss that might last a few days or weeks. And disability, unfortunately, may accrue over time due to neurodegeneration. And this can happen even independent of relapses as patients have the disease over long periods of time. In multiple sclerosis, we know the immune system is targeting myelin, which is the protective coating that is wrapped around the axons, or the nerves, the main cells in the central nervous system. As the immune system attacks and damages the myelin, the nerves, or the axons, also become damaged, and that's when the symptoms arise, depending on where the inflammation is. So as I alluded to, if the optic nerve is being damaged by the immune system and the myelin is lost around the optic nerve, patients can get eye pain and vision loss. So let's look at a patient who has optic neuritis due to MS. This is a 38-year-old female, and she started having blurry vision and pain on eye movement about 3 to 4 days ago in her left eye. About 1 year ago, she noticed some tingling in her left hand, and she thought it might be related to carpal tunnel syndrome, but she never actually sought treatment about it because those symptoms went away. So she came to me, and on her exam, her visual acuity in the right eye was normal, 20/20, and in the left eye was diminished at 20/80. Her visual fields were normal in the right eye, but she clearly had some vision loss in her visual field in the left eye, and she had color vision loss in the left eye also, which is a key feature of optic neuritis. And when I did an exam shining a bright light in her eyes, there was something called an afferent pupillary defect in the left eye. That's a sign that when we see it on exam, points to damage in the optic nerve. The rest of her neurologic exam was normal. So this is a slide that highlights what an afferent pupillary defect looks like. On the top part of this slide, there is a light being shined in the right eye. You can see both pupils are constricting. When the light gets shown over to the left eye, you can see the pupils dilate. And again, this is a sign that there's damage to the optic nerve. And in a young patient like this, it's very commonly due to optic neuritis from MS. Here's our visual field test. On the right side, you can see a normal visual field, and I'm sure you can all appreciate the vision loss on the left side in the darkened area of our visual field. And so I ordered an MRI of the brain and orbits, the orbits being the eyes. And what we can see here on this MRI is a normal optic nerve on the right here. And on the left, there's inflammation in the optic nerve. This inflammation is being seen when the contrast leaks into the optic nerve. The contrast is given through an IV, which I'm sure many in the audience have had before. This patient's MRI also showed multiple lesions consistent with multiple sclerosis. If you haven't seen an MRI before, the top two MRIs are what we call T2 sequences, and the bottom two sequences are the contrast-enhancing lesions. Normally, the contrast should not leak into the brain, so when we see this, we know there's active inflammation from the multiple sclerosis. And the shape, size, and location of these lesions are highly suggestive of multiple sclerosis. 8 weeks later, she did not have any treatment. Her vision spontaneously improved. Her eye pain was gone, and she was seeing 20/20 again. And as you can note on the visual field test, her visual field returned to normal. Her color vision also returned back to normal. This is typically what happens to most patients who have optic neuritis due to multiple sclerosis. Even without treatment with steroids, they have a good prognosis for full recovery or near full recovery. Sometimes the vision is not quite 100% back to normal, but it usually gets pretty close. Sometimes patients do get steroids to hasten the recovery of their vision loss. We did blood work to look for those other diseases I mentioned. NMO, we checked for the aquaporin-4 antibody. We'll talk more about that later. We also checked for the MOG antibody, and they were both negative in her blood work. She also had a spinal tap, and her spinal tap showed illegal clonal bands, again, confirming that she has multiple sclerosis. And lastly, we did an OCT scan, which stands for optical coherence tomography. If any of you have been to an ophthalmologist or an ophthalmologist's office, you might have had this test done where we take pictures of the back of the eye, and we can actually measure down to the micron level the thickness of the retina around the optic nerve. Anybody who's had optic nerve damage will show thinning eventually over time in the retinal nerve fiber layer on this machine. So we can see here she had normal thickness in the right eye, 98 microns, but she lost about 10 microns in the left eye. She was then started on a medication for treating her MS and got much better. So in summary, MS can cause relapses such as optic neuritis, and early on, patients with MS frequently will recover from the relapses, whether they're treated with or without steroids. And optic neuritis in MS generally has a favorable prognosis with good recovery of vision. Now let's look at another disease, NMO or NMOSD, also used to be known as Devick's disease. This too is an autoimmune disease affecting the central nervous system, which again is the optic nerve, the brain, and the spinal cord. This can cause symptoms through relapses, for example, optic neuritis, and disability. However, the disability accrues because of the relapses, and unfortunately with NMO, the relapses can cause permanent disability, and the recovery might not be good. Even with treatment with steroids, some patients end up with permanent vision loss or other symptoms, which we'll discuss later. The immune system in NMO targets a protein in the central nervous system called aquaporin 4. Hence, when we look for NMO disease, we check the blood for the aquaporin 4 antibody, which is a marker of the disease. The aquaporin 4 binds to astrocytes, which are one of the major important cells in the central nervous system that help support brain health. As the astrocytes get damaged, other cells in this brain or optic nerve or spinal cord also get damaged, leading to demyelination and axonal loss and permanent disability in some cases. In optic neuritis and NMO, the immune system is attacking the astrocytes in the optic nerve, and that can lead to severe permanent vision loss. So here's a case of a female, very similar, 38 years old, with blurred vision and pain in the left eye, just like our last patient. Came on over 3 to 4 days. Pain was worse with eye movement, just like our patient with MS. She also had some tingling, which she attributed to carpal tunnel a year ago. But interestingly, she also had this episode a year ago where she had intractable nausea, vomiting, and hiccups that went on for several weeks. She was hospitalized, and the doctors couldn't figure out what was causing it. She had a colonoscopy, a CAT scan. They had blood work done, but they couldn't figure out if it was an infection. But they ruled out that she didn't have any inflammatory bowel disease or any other infections. The symptoms got better on their own, and she kind of forgot about it until I asked her about it. On exam, she had 20/20 vision in the right eye. Her vision loss, though, in the left eye was much more severe. She was down to count fingers vision, meaning she couldn't even see the big E on the eye chart across the room. She had a large blind spot in the left eye. She couldn't see any of the color plates, and she also had an afferent pupillary defect in the left eye, telling me she had optic nerve damage. And here's her MRI, and here we can see the optic nerve in the left eye is strongly enhancing with contrast. And if you note, it's almost the entire length of the optic nerve that is enhancing. We call that longitudinally extensive optic neuritis. And that's a tip-off to think about NMO when your neurologist sees that on the MRI scan. We can also see just a very bright, avid enhancement of the entire optic nerve in the left eye in these MRI scans. She was treated with steroids because we felt that this was pretty severe vision loss. And after 5 days of IV steroids, she really did not have any significant improvement in the vision loss. She still was only seeing count fingers vision. We then opted to treat her with something called plasmapheresis or plasma exchange, which required her to stay in the hospital for an additional week. 2 months later, her vision was still 20/20 in the right eye. However, the vision in the left eye only improved to 2400 vision. Again, that means that she was able to finally see that big E on the eye chart, but nothing smaller. So you can see here, in distinction to MS, patients with optic neuritis due to NMO frequently have severe vision loss that sometimes does not recover even with aggressive treatment with steroids or plasmapheresis. Her blood work did confirm the diagnosis of NMO when she had the positive aquaporin 4 antibody test come back. Not everybody with NMO has a positive test. It only comes back positive about 80% of the time, so sometimes patients have negative antibodies. A spinal tap was done, and she had no illegal clonal bands, which is also typical in NMO. And 3 months later, we looked at that OCT scan, and if you remember our prior patient, she only had about 10 microns loss of her retinal nerve fibrillator, whereas in our patient, she lost 40 microns. She was 98 in the right eye and 58 in the left eye. This is just some studies reviewing the differences in OCT between patients with MS and NMO. And you can see with optic neuritis due to multiple sclerosis, patients' microns measure in the 70 to 88 range, whereas with NMO, the thinning is much worse in the 55 to 63 range, confirming that the damage to the optic nerves is more severe in optic neuritis due to NMO. This is just a picture of what an OCT scan looks like. So if you're looking at this, on the left side of the screen is the right eye, and on the right side of the screen is the left eye. On the top are the black and white pictures of the actual optic nerves within those green circles. And then the bottom is just measurements looking at the actual thickness. And the left optic nerve is normal, so all those numbers are in the green there, highlighting normal, whereas the red areas around the optic nerve are highlighting the damaged thinning of the optic nerve in the right eye. This is a different patient I'm showing here, because our patient had optic neuritis in the right eye. In the left eye, this is a patient with optic neuritis in the right eye. So a little bit more about NMO. So it can affect individuals of all races. The prevalence is about 1 to 10 per 100,000, and it seems to be similar worldwide. There have been higher reports reported of NMO in patients of African ancestry in the Caribbean and also in the Far East. It typically affects females to males 9 to 1 ratio, so it's much more common in females than males. If you think about multiple sclerosis, there's a slight preponderance of females to males, but it's only about 2 to 3 to 1 ratio. Whereas in NMO, it's a much more female predominant disease, 9 to 1 ratio. Again, it's an autoimmune disorder associated with this aquaporin 4 antibody in the blood. And not only can it cause optic neuritis, but it can cause inflammation in the spinal cord, which is called transverse myelitis, or this area postrema syndrome. I kind of alluded to that earlier in my case when I talked about the nausea, vomiting, and hiccups. The area postrema is a part of the brain that controls your nausea. And so if you have any noxious stimuli to that part of the brain, that can induce nausea and vomiting. And for some reason, there's a lot of aquaporin 4 channels in that part of the brain. So if patients have NMO, they are at higher risk for developing this syndrome. So it seems that the prognosis in general for NMO is worse compared to MS, in particular with optic neuritis, but also with transverse myelitis. They tend not to have as good a recovery even with aggressive treatment. 41% of patients with aquaporin 4 positive NMO will be legally blind in at least one eye 5 years after the disease onset. If you look at the visual prognosis from a Mayo Clinic study, at follow-up 8 years after disease onset, more than half of their patients were legally blind in one eye. But one thing to keep in mind is a lot of these studies were done before the era of treatments were available for this disease. It's a little bit different now, as I'll allude to later in the talk. There are now several approved medications for the treatment of NMO. However, they found that 15% of their patients, again, this is in a patient population looking from previously, were blind in both eyes. So can we prevent this from happening? The answer is yes, but we'll talk a little bit more about that later. I just wanted to highlight the transverse myelitis. I've been showing a lot of optic nerve MRIs. This is showing here a really extensive longitudinal inflammation of the spinal cord. And this is another tip-off that we're dealing with NMO. Typically in multiple sclerosis, a small single segment of the spinal cord is inflamed. So with NMO, we see at least 3 or longer segments of the spinal cord having inflammation, leading to weakness or paralysis of the arms and or legs. This can also lead to bladder dysfunction, unfortunately, too. 22% of patients with NMO may require a walker at 5 years. 8% may be wheelchair-bound by 5 years. And 50% of the time, the first attack in an NMO patient might be inflammation of the spinal cord or transverse myelitis. This is showing the MRI of somebody who has that area postrema syndrome. Again, they can present with intractable nausea, vomiting, or hiccups, not just lasting a few minutes, but typically several days in length. And no underlying cause can be found when you study the abdomen or if you have a colonoscopy or CT scan of the chest, abdomen, or pelvis. Those will all be normal. Finally, we're going to talk about MOG disease. MOG is a more recently diagnosed or recognized entity. It stands for myelin oligodendrocyte oligoprotein. MOG is another protein in the central nervous system. It's found in the myelin, which again we alluded to is damaged in multiple sclerosis. However, we think now that patients with MS don't have the antibodies to MOG, whereas patients with MOG disease or MOGAD have these antibodies. Again, they can have inflammation in the optic nerve, the spinal cord, or the brain. And the symptoms can be recurrent optic neuritis, transverse myelitis, or another syndrome called ADEM, acute disseminated encephalomyelitis. So the immune system with MOG is targeting the myelin oligodendrocyte glycoprotein. It's found in the myelin, again in the central nervous system. And when this happens, symptoms arise that sometimes will get better with steroids. And in MOG, what's really interesting is that patients frequently will have bilateral optic neuritis. It might be coming on simultaneously where there's blindness in both eyes. Here's another case that we're going to look at of optic neuritis, but here due to MOG. We have a 38-year-old female who had left eye pain 3 days ago. She had foggy vision when she woke up, and it looked like she was looking through a dirty window. She actually had a similar episode in 2009 involving her right eye. At that point, when she had the optic neuritis, a year later she had transverse myelitis, and she was thought to have multiple sclerosis. She was therefore started on a disease therapy for MS called beta-seron, which she was injecting. And until this current attack, she had actually been doing quite well without any relapses. Her vision was down to 20/60 vision in the left eye. She had a little bit of color vision loss in the left eye, and she had that afferent pupillary defect, again confirming that she has optic nerve damage. Her visual fields were constricted in the left eye. And during the exam, she was noticing that she had pain on eye movements, which is also a typical finding when patients have optic neuritis. And I'm showing here the pictures of her optic nerves when we look in the back of the eyes. So these are dilated fundus photos. The right eye, the optic nerve looks normal, but on the right side of the screen here, the optic nerve looks slightly swollen. It might be hard to see the difference, but the optic nerve is slightly swollen, which typically does not happen with optic neuritis. In most cases of optic neuritis, when we look back at the optic nerve, it looks normal. But with MOG, there seems to be a higher tendency for the optic nerve when we look at it to look swollen in the back of the eye. Here's a higher magnification photo showing that swelling of the left optic nerve again. And if we look at the MRI scan, again, we can see pretty significant enhancement of the left optic nerve on the MRI scan. And so the rest of the MRI looked normal, which I thought was a little odd because she had the diagnosis of MS. And typically with MS, we'll see lesions in the MRI. So we thought maybe we should check antibody testing. And we checked for aquaporin 4, that was negative, but the MOG antibody test came back positive. So we changed our diagnosis from MS to MOG, and we didn't think that the medication, the beta-seron, was appropriate anymore. Some other features of MOG optic neuritis. So MOG optic neuritis typically is recurrent. It can frequently be bilateral, and the swelling of the optic nerve known as disc edema can occur in 85% of cases. And there can be really extensive enhancement of the optic nerve, just like we see with NMO. Sometimes we're not 100% sure we can tell the difference between NMO and MOG when we look on the MRI scans, but there are some things that might tip us off. If we see the optic nerve sheath, the wrapping of the myelin around the optic nerve itself also enhancing, that could be a tip-off that it's MOG. If its optic nerves are swollen, as you can see here in both eyes, that's another clue that it might be MOG and not aquaporin 4 disease. And then if we see the more anterior aspect of the optic nerve enhancing, that's a tip-off that it might be MOG disease, where if it's more posterior near something called the chiasm, where the two optic nerves meet near the brain, that might be a tip-off that it's more NMO or aquaporin 4 disease. But there's always exceptions to the rules, so we still always have to check the blood work. This is just a table highlighting some of the differences between MOG disease and aquaporin 4. I'm not going to read it all, but I'm going to highlight a few things that I think stand out. One is that MOG disease is frequently more common in the pediatric population. These kids can sometimes have recurrent attacks of optic neuritis, transverse myelitis, or ADEM, I alluded to earlier, acute disseminated encephalomyelitis, where they can have confusion or delirium associated with large lesions on the MRI of the brain. As far as the gender predilection, again, aquaporin 4 disease, much more common in females, about a 9-to-1 ratio, whereas MOG disease, there's some evidence that it's actually equally affecting males and females. There can be bilateral optic nerve disease simultaneously with MOG disease, much more common there. It can happen with NMO, but it's less common. The recovery tends to be much worse with NMO. With MOG disease, patients tend to get much better with steroids, but one thing that we do note with MOG disease is sometimes when we stop the steroids, their disease will flare up again, and then we have to restart the steroids. So that's one tip-off that might make us think about MOG disease. And there's a part of the spinal cord that frequently is involved with MOG transverse myelitis called the conus, which is the very bottom of the spinal cord. That is not typically associated with MS or NMO disease, but is more frequently seen with MOG. You don't have to remember this. It's important for your neurologist to recognize all this, but I don't expect all of you to recognize all this. I'll just highlight here again some findings on the MRI in MOG optic neuritis. Again, here's another case where there's bilateral enhancement of the optic nerves. It's a little bit worse in the left optic nerve, but both nerves are showing enhancement. So again, if you're thinking about MOG disease, it affects men and women equally. They have very frequent risk of relapses, particularly in pediatric patients, of optic neuritis, ADEM, or transverse myelitis. I have to say though, because MOG is kind of a new disease, we don't even have official diagnostic criteria for it yet. We don't know the exact incidence and prevalence, but there's some suspicion amongst many MS specialists that there might be a significant minority of patients who have this who were initially thought to have MS. So what do we do about this? Well, we have to do more testing. We have to study this disease more, and there are more trials going on to investigate this more, including studies to look at treatment options for this. So this is just highlighting again MS female to male ratio 2-to-1, so it's much more common to have males having MS. MS by far is still thought to be the most common central nervous system disease causing demyelination in young adults. There's about 1 million people in the United States with MS. There is no antibody associated with multiple sclerosis though. So why is it important to know about these 3 different diseases? They have different prognosis. NMO by far has the worst prognosis. MOG seems to have a pretty good prognosis if we can control the disease, although there's a high risk of relapses. We know MS has variable prognosis depending on each individual, and it can be hard to predict the prognosis in general. So you have to really think about different presentations of MS. Patients with primary progressive MS may have a worse prognosis, whereas those with relapsing MS who start treatment early might have a better prognosis. Treatments for NMO. So we now have 3 FDA-approved treatments, which I'll talk about. But if patients have a relapse, we frequently will hospitalize them because we know NMO relapses can be quite severe. We'll do IV steroids early on, and if those don't work, we might next initiate treatment with plasmapheresis or PLEX. This is not something we typically use for multiple sclerosis, however. Typically, MS relapses will either not treat, or if we do treat, we'll treat with steroids alone. Patients with NMO also frequently will need physical therapy, occupational therapy, and if they have significant vision loss, possibly a referral to a low vision clinic. So prior to 2019, there were no FDA-approved medications for NMO-SD. Many patients have been treated off-label with a medication called rituximab, which is an IV infusion, and it's still used a lot today because many patients were already on that therapy. However, the first drug approved by the FDA for treating aquaporin 4 positive patients with NMO was eculizumab, which blocks a part of the immune system called complement. So it's only approved for adults right now, but we are investigating it actively in pediatric patients, and we might have the results of that trial in a year or so. This IV infusion has to be given every 2 weeks and takes about 35 minutes to infuse. Patients do have to get vaccinated before starting this therapy because it can increase the risk of something called meningococcal meningitis. 2 other medications that were approved last year by the FDA for aquaporin 4 positive NMO-SD were satralizumab and inebilizumab. These are also monoclonal antibodies. Satralizumab is a monoclonal antibody blocking interleukin-6 receptors, and it's actually something that a patient can self-inject at home once every 4 weeks. Because it's modulating the immune system, can also increase the risk of infections. Inebilizumab is an IV infusion. Like rituximab, it's infused every 6 months. It blocks a slightly different part of the B cells, but it's similar to rituximab that it's blocking B cells. Again, it might increase the risk of infections. So when we think about treatment for NMO, once we recognize somebody has it, we need to start them on one of these therapies as soon as possible, whether it's rituximab or one of the 3 FDA-approved therapies I already mentioned. Once somebody has aquaporin 4 disease, NMO, they're at very high risk for relapses and disability and morbidity. And so the name of the game is prevention of relapses with NMO-SD. We don't want patients going blind, becoming wheelchair bound, or in very rare cases, dying from the complications of their attacks. So once we diagnose somebody with NMO, we get them on treatment as soon as possible. If you're antibody negative and you have NMO, we don't have approved therapies by the FDA yet, but there are therapies that we can still use that suppress the immune system. Also for MOG disease, again, there are unfortunately no FDA-approved therapies yet, but there are clinical trials that are going to be starting soon to look into therapies that might work. One of these is going to be investigating satralizumab to see if that might help prevent relapses in patients with MOG disease. Sometimes we treat patients with MOG disease with other medications like rituximab, mycophenolate, or azathioprine. So in closing, if you have NMO or you want to find out more information, or if you have MOG disease, or even if you don't have these diseases, you want to learn more, there are patient support groups, the Guthrie-Jackson Foundation. You can go to their website listed here, and also the Samara Foundation have great resources on them that will fill you in on more information both about NMO and MOG. Thank you again very much for your attention, and it was a pleasure seeing you all today.
All right. Well, even though he's not here, I want to thank Dr. Osborne for that presentation. It's really amazing how much things are changing and how much things have changed in just a short period of time in our understanding of NMO compared to MS, and the ability to have treatment options. Wonderful. Again, we have sponsors supporting this program who have some of the products that Dr. Osborne mentioned. So I guess I can introduce myself because I'm the next speaker. So I'm Bob Shin, and I do neurology and neuro-ophthalmology here at Georgetown. The topic that I wanted to cover today is something that I've been interested in increasingly, not just because of what's been going on, I think, around us sort of in society, but just really things that we've been learning within the multiple sclerosis space. So my topic today is on race, sex, and multiple sclerosis. So when we talk about MS, we often have sort of very standard things that we say. The first thing we say is that, well, multiple sclerosis is an inflammatory autoimmune condition that causes demyelination in the central nervous system, the brain, the spinal cord, and the optic nerves. And that is true. But other things that we usually emphasize is that MS affects women more than men. And we often have emphasized that MS seems to be more common in people of Northern European ancestry, meaning people who are white. I think maybe many of us on this call have heard this. I, as a professor, have said this and taught this to students for maybe decades. This is Selma Blair, who's a celebrity who recently revealed that she has a diagnosis of multiple sclerosis, and she's a young Caucasian woman with this diagnosis. This is sort of the stereotype of MS that we think of. But it has been recognized for a long time that even though we say it's not as common in people of color or not as common in men, we've recognized that when men are diagnosed with MS, they seem to do worse. We've also recognized that African Americans who are diagnosed with MS seem to do worse. It's also appeared that, in particular, African American men have a particularly bad disease course with multiple sclerosis, with more aggressive disease and greater disability. These are two more celebrities. So on the left is Ozzy Osbourne's son, Jack Osbourne, who revealed that he has an MS diagnosis. And on the right is Montel Williams, who had become sort of a MS sort of advocate and has different sort of projects that he supports. But this would be an example of people diagnosed with multiple sclerosis, but who might be men or African American. So the question has come out, like, why is this? Like, why do we see that African Americans seem to have a worse outcome from MS or more aggressive disease? Why do men have such a rough time with their multiple sclerosis? And a lot of focus had been placed on things like looking for maybe genetic markers, like just looking genetically, like what's different between Caucasians and African Americans, for example. And so you might even want to look at, well, what are the genetics of multiple sclerosis? And we've covered this maybe on previous talks, but if you just look at the average American, we've now updated our statistics and we say that, wow, you know, almost 1 million Americans have MS. That means that really, as an American, your risk of having MS is roughly 1 in 300. Now, we've also observed that, of course, what if you have a family member, a close relative, maybe a child, a sibling, or a parent with multiple sclerosis? What is your risk of MS? And it's actually, it isn't 1 in 300, it's more like 1 in 30. So that is an increased risk by having a first degree family member. I usually emphasize a lot of my patients, maybe they come to me when they might be thinking of having a family, and I'm like, well, you know, your risk of having a child with MS is really low. Like, I mean, if you had 30 children, you know, I guess one might have multiple sclerosis. But again, if we look at the statistics, we do see a slight difference. Now, what about identical twins? Because remember, if you have an identical twin, you have two people who are genetically identical. If I said one of these twins has multiple sclerosis, and I ask you, what is the chance the other twin also has multiple sclerosis? Well, the answer is 1 in 3. So 1 in 300, 1 in 30, 1 in 3. But, you know, interestingly, if you ask me to bet money, I would say I bet the other twin doesn't have MS, because 2 out of 3 times they don't have MS. So it tells you, well, okay, the genes may have some role, but they basically don't determine whether or not you have multiple sclerosis. In fact, we've been doing studies for years, really decades, trying to find different markers, different alleles, different genetic variations that identify risk for multiple sclerosis. And there's been attention to the, you know, chromosome number 6 and all of these different genes. And I do have to say, you know, you can find studies and research will say, well, maybe, you know, the presence of this gene may increase the risk by like 1% or 2, like very, very small amounts. But I just have to be honest and say that despite decades of research into the genetics of MS, we have not been able to find any useful genetic markers that tell us that one person has a greater risk of multiple sclerosis in any meaningful way, which is, so it's so difficult. It's like, but we observe that African Americans with MS seem to have a worse prognosis. Why can't we figure out what's behind that genetically? Well, I would argue that maybe some of this is because what we mean by race is really unclear. So I'm just using these examples. President Obama has one white parent and one black parent. We identify him as our first black president, but he has as much Northern European ancestry as he does African ancestry, if you really think about it. So 50% white in the US is black, or if you look at Trevor Noah, again, just like Barack Obama had one white parent, his father, who was German, and one African parent, his mother, who's a black South African. He was excited to come to the United States where he could actually be black because, in South Africa, he's not considered black since he has one white parent. So his friends were like, no, go to America. You're going to be black when you go there. You look at in the lower right-hand corner, Tiger Woods. So sort of lauded as like, one of the world's best golfers, a black golfer. Interestingly, in his ancestry, he's really 50% Asian. Really, I don't know why we're not embracing him as like the great Asian golfer. His mother is Thai and Chinese, and his father is half white, half black. So really, Tiger Woods is only 25% black, but again, he's a black golfer in the United States. And then I just added this picture because I'm sort of nerdy. And do you know who Jennifer Beals is? Do you remember her from Flashdance? Like, I remember growing up, like the most attractive outfit that I remember seeing in like middle school and high school was like women wearing leg warmers. We're like, wow, that's such a cool look. I love the leg warmer look from Flashdance. And now she's going to be in a Star Wars TV series, the Book of Fett, or she's going to be a Twi'lek in this Star Wars TV series. But, Jennifer Beals, I didn't actually know this until recently, has one white parent and one black parent. She grew up in a predominantly African-American neighborhood where she was teased and she was called Whitey because her skin was so light. And she was always embarrassed that her skin was so light. But my point being that, what does it even mean to be black or white in the United States? It doesn't make sense to me that we're trying to find some sort of genetic reason why African Americans have a worse prognosis when they're not different populations. In fact, some people have made the statement, and this is Bill Nye, the science guy, would basically say there really is no such thing as race. It doesn't actually exist. Or Toni Morrison would say it's really just a social construct. Why would we say this, like that race doesn't exist? Well, it's because judging race, if we're really honest about it in the United States, is mostly about judging you based on the color of your skin. Like I said, Jennifer Beals, I thought she was white. Tiger Woods, I think that he's black. It's really just how much pigment is in your skin. And that really just has to do with where did your ancestors come from? What part of the planet did your ancestors come from is all that's going to determine the color of your skin. Okay. And so this is just a map showing you human skin pigmentation. It's not random. You can see there's a clear pattern of where pigmented skin is and non-pigmented skin is in the far north. And why is it like this? Well, it's actually crystal clear because this is the map of ultraviolet radiation on our planet. You can see, just look at these maps. It's exactly identical. So around the equator and wherever we get the most ultraviolet radiation exposure on our planet is where human beings have the darkest skin. Basically, all skin color is how much sunscreen do you have built into your skin. So, again, the idea that there is something significant about the color of your skin, I think we could call it into question. So you could see people say, well, race doesn't exist. Well, I have to say, I do think that's a little bit simplistic, right? That to say that race doesn't exist. I think what would be more accurate is to say race, based on skin color, as far as we can tell, doesn't have any deterministic or biological basis, which maybe explains why our MS genetic studies haven't really shown us anything. But I think if on this call, we're all honest, race is extremely powerful, right? So all the same, race is so powerful that it can have life or death consequences because we treat each other differently based on the color of our skin. In terms of life or death consequences, this is a graph. This happens to be a graph of infant mortality in the United States today, okay? The world's most wealthy country with arguably, the best access to healthcare. If for every 1,000 babies that are born, okay, 11 Black babies don't make it. They die in delivery. On the other hand, white babies, basically only less than half as many white babies die in childbirth. So just by being Black or white, basically there's a significant difference in the likelihood of surviving being born. Okay, so Black babies are twice as likely to die as white babies. And then for their mothers, and this is now for every 100,000 deliveries, you can see if you compare the left and the right column, if you're a Black woman having a baby, you are 3 times more likely to die than if you're a white woman having a baby in the United States today. Interestingly, studies have shown recently that you can actually cut this in half, the risk of dying, whether you're a baby or a mother because you're Black. You can cut that risk in half if the main doctor in charge of your care is African American. So just having a medical provider that is African American reduces this kind of shocking discrepancy. And in this context, people are not really trying to find some genetic reason for this, because sure, there are socioeconomic determinants of healthcare. Lack of access to healthcare, socioeconomic difference, but actually even accounting for those things does not explain this discrepancy. And studies have suggested that it's actually due to racial and gender discrimination that we see this much of a discrepancy between people who are Black and who are white when it comes to having children. So, it really makes me wonder whether we should re-examine our assumptions. Again, MS facts, question mark. Certainly central nervous system demyelination, fine, but this idea, let's say that it's more common in people of Northern European ancestry, is that even true? Well, actually, Mitch Willeen, who's here in DC and part of the Georgetown faculty and works at the VA, was in charge of a study, and you looking at actually soldiers or veterans, people enrolled in the military for over a decade, and just looking, these are young adults who are men and women who are enrolling in the military and keeping track of them. I'm not going to go into it in a lot of detail, but just to show you that in this broad survey of young adults, it turns out the likelihood of being diagnosed with MS was not different if you're white or if you're Black. It was the same. Actually, if anything, there was perhaps a slightly increased incidence of MS if you were African-American, particularly if you're an African-American woman. And other studies have actually confirmed this. So this fact that I am guilty of having taught other people turns out to be incorrect. In the United States, it doesn't matter if you're Black or you're white. The risk of MS is the same. I've had so many African-American patients who have had a similar story where, they were told things like, oh, by the physician, oh my gosh, you have a white person disease, or being told things like, you're the wrong race, but it looks like you have optic neuritis. And so this stereotype that has been propagated that MS is more common in people who are white, basically we need to correct this because it is factually incorrect. How about even this idea that MS affects women more than men? Well, I mean, technically that is sort of true in that we do see more women diagnosed with MS than men. Interestingly, in the past, the ratio of women to men was, we would see 1.4 women diagnosed with MS for every 1 man, 1.4 to 1. That's not that discrepant. And then over time, it seemed like, it seems like twice as many women as are being diagnosed with MS as men. And research I've been, wow, it seems like 3 times as many women as men are being diagnosed with MS. And so everyone's like, oh, I wonder what's going on here. Why are more and more women being diagnosed with MS? I would say, is it possible it's because we keep telling everybody that women are the primary people who are diagnosed with MS? What if we're just underdiagnosing it in men because we keep telling everybody that MS predominantly affects women? Now, why would that even matter? Well, I'm just going to use an example of, let's say, heart attacks, okay? Because I don't know if you know this, but basically 3 to 5 times as many men have heart attacks as women. Heart attack is more common in men than in women. But I would say that we never emphasize that. We don't talk about it because you know what we also learned is that when women have heart attacks, they're more likely to die. Why would this be? Women have less of the risk factors that men have, but they're more likely to die. And we think it's because it was being under-recognized in women. So when you look at the CDC, when you look at any literature on heart attack, they say signs of a heart attack, and there's a man and a woman, and they don't emphasize one over there, like men and women, they all have to recognize the signs of a heart attack. And we even recognize that for some women, the symptom they complain of is a little bit different than what men might complain of, but we don't emphasize that it's men more than women. We say, no, these are the signs of a heart attack. We need to recognize heart attack in men and women to make sure that women are not dying from having under-recognized heart attacks. So I wonder, wow, I wonder if the same thing could be happening in MS. You know, we're like, oh, well, MS, it affects women more than men. Oh, but when men do get diagnosed with MS, they seem to do worse. I worry that, gee, what if there's some other factor? What if it's not genetic? What if it's not hormonal? It's just that we're under-recognizing it in certain populations. So here's a patient that really made me think about this, because he's a 28-year-old smart guy, government contractor in IT, and he had an episode of vision loss in his left eye in 2011. And again, smart guy. So he's like, he asked his doctor, do you think I should get a brain MRI? And the doctor's like, yeah, no, it's not like you have multiple sclerosis. It's just optic, right? So he's like, okay, I guess I'm all right. I met him in 2019 because he had developed episodes of pins and needles, which is like, that was fine. He could shake that off. But when he started to have imbalance, he came to seek medical attention and saw me. And we did an MRI, and he had tons of MS lesions all over his brain and spinal cord. Very advanced disease at that point. And I was like, wow, this is unfortunate. And when I think about it, because he had optic neuritis 8 years ago, we probably could have figured it out 8 years ago. Why the delay? Well, I mean, this isn't his exact picture, but this is kind of what he looked like. He was a large, muscular African-American man with dreadlocks and actually tattooed sleeves all the way up and down his arms. And so, you know, I had to admit, I was like, this guy had a delayed diagnosis because he didn't look the part. He wasn't a young Caucasian woman. He was a muscular, dreadlock, tattooed African-American male. And that made me really think about like what factors go into our diagnosing people with MS. Why would it even matter if the diagnosis is delayed? Well, I just randomly grabbed like 6 different studies. They all show the same thing. Every single study of every single MS medication that's approved has always shown the same thing, which is that if treatment is delayed, even by a year or two, the delayed treatment group has more disability. And it doesn't matter how long you treat them after that, they never catch up to the people who got put on treatment from the very beginning. So in stroke, we say time is brain, but this is true in multiple sclerosis as well. A delay in diagnosis leads to more disability. All right. So it's really important for us to minimize delays in diagnosis. So I thought, well, maybe we could look at this. So this is sort of a heat map, if you will, of the United States showing where African Americans live in the United States. So it's not only 15% of the US population is African American, and African Americans are not evenly distributed in our country. Okay. For, I think, obvious historical reasons, there is an increased density of African Americans in the southeastern United States. And look at where we are. I put the arrow, you know, as it happens, we're sort of a hotspot. So this Washington, D.C., Northern Virginia area has a very high concentration of African Americans. So I thought, well, maybe we should try to look at sort of diagnosis of MS in people who are either Caucasian or African American. So we did a very simple survey. Dr. Brian Barry, who's the MS director at Washington Hospital Center, was our fellow participating in this, and Amy Safadi, who's an incoming fellow with us. We worked together to create this little simple survey. We just asked people, well, when was your first neurologic symptom? And then the second question, well, when did you first see a neurologist? Third question, when did you officially get diagnosed with MS? And so maybe there are people on this call who participate in this. We just put together a little survey. At this point, we have over 200 patients who were willing to answer those 3 questions. And these are some of the results. First of all, in my practice, or I guess our practice, I have the same number of Black as white patients with MS. So I actually slightly greater, right? So 48% Black, 47% white. So again, this idea that, well, it primarily affects Caucasian people, it just isn't true. But what I wanted to highlight here, and again, this might be a little bit small on the screen, but there's a really striking difference whether you are a man or a woman. Because if you're a woman, the typical time it took before you got to see a neurologist was about 2 months. And then after, or, from your symptoms to seeing the neurologist about 2 months. And then it took another month or so to get the diagnosis. So the typical time from your initial symptom to getting your MS diagnosis was 6 months if you're a woman. Okay, that was the median time. But if you are a man, there was a very significant delay in the time that it would take first to see the neurologist and then to get the diagnosis. So that the typical time, it took men almost 2 years to get diagnosed with MS. This is just men versus women in our little survey. So again, this observation that men do worse, that men are more likely to have progressive disease, that men are convert to progressive disease more rapidly. I would say, well, what if part of this has to do with the fact that we seem to diagnose MS later in men for a variety of factors? Now, when we looked at it by race, we also saw, I thought, something interesting. Now, if you just look at from your initial symptom to when you saw a neurologist, this could be whether somebody sent you to a neurologist or whether you went to go see a doctor. It doesn't matter how it happened. But if you look at white women, the median time from having a symptom to being seen by a neurologist was 1 month. It's pretty fast. You had a weird symptom, went to go see a doctor and got sent to a neurologist pretty quickly. It was a little bit delayed if you were African-American. If you're an African-American woman, it might take 2 months before you were seen by a neurologist. And then you can see that for men, it's much longer. For a white man, it might take 4 months before you got to see a neurologist. If you're a Black man, it might take up to almost a year before you were even seen by a neurologist. Now, how about once you see the neurologist? And again, keep in mind, this is sort of our own practice here at Georgetown. I like to think maybe we are good at MS, maybe we're knowledgeable about MS, maybe we should be able to figure it out. But even in our own survey, if you're a white woman or a Black woman for that matter, once you got to see us, once you got to see a neurologist, we did figure it out fairly quickly. Typically, it would take us about a month to get the test done and to come up with the diagnosis of MS. But you can see that for men, it is a little bit delayed. It takes us a little bit longer if you're a white man and a little bit longer than that if you're a Black man. And so if you put them together from your initial symptom to seeing the neurologist to getting the diagnosis, you can see for a white woman, at least in our survey, it might take you 2 months between having the symptom, seeing the neurologist, getting it would take you 2 months. If you were a Black woman, it seemed to take a little bit longer, not that much longer. But look at our men. A white man, it could take between the symptoms, seeing the neurologist and getting it could take 6 months. And then if you were a Black man, it could take over a year from having the symptom to seeing the neurologist to getting diagnosed. And I thought that these data were interesting when you look at the observations that men seem to have a worse prognosis than women, and that African Americans have a worse prognosis than Caucasians. What if at least part of this effect is that we, the healthcare providers, are slower to recognize MS if you're not the stereotype, if you're not a young white woman? So I just wanted to end this by basically proposing that we sort of change how we talk about this disease. So these MS facts, 2 out of these 3 facts, I feel like we need to change. Sure, central nervous system demyelination, but I think the message should be that MS affects women and men, and that we need to recognize the symptoms of MS in women and men, and we need to get people to medical attention, whether you're a man or, just like for heart attack, just like we spend a lot of energy to get people to recognize the signs of heart attack in women so that we don't underdiagnose it in women and so that they don't have a worse outcome from heart attack. I think we need to do the same for men, that we need to be reaching out to our relatives and our friends. We need to reach out into the communities. And let's be honest, men, studies have shown this, are reluctant to seek medical attention. But we need to get the word out there that if you're having blurred vision, double vision, weird numbness and tingling, imbalance, anything like that, you need to seek medical attention. And I think we need to basically delete the lie that MS predominantly affects people who are white and recognize that MS affects people of all races. And again, we need to be out in the community, educating each other. We need to educate ourselves, I mean, healthcare providers, we need to educate each other to get rid of this misconception. Why? Because we're fortunate to have incredibly effective MS treatment options, but they only work when we correctly identify the disease as early as possible. So it's really important that we get these things right from the very beginning. All right, thank you. So Bethany, I don't know if maybe you should share screen because I think we're moving into our break. Is that right?
Yes, we are going to take a break now, and we'll see everyone back at 9:55. We have a short video that we will share, and we hope that you will also visit the virtual exhibit hall.
Dear MS, to say that you totally misrepresented yourself when we first met is an understatement. I hated you because in the prime of my life, you barged in and dominated it. You took my confidence and replaced it with uncertainty. But guess what, MS? You underestimated me. And I realize now that you didn't take everything from me. You actually gave me some things too. Like perspective, to not take life for granted. I only have this to say. Get out of here, you punk. You picked the wrong woman to fight. Kimberly.
Ocrevus is for adults with relapsing or primary progressive forms of multiple sclerosis. Don't take Ocrevus if you've had a life-threatening allergic reaction to it or have hepatitis B. Tell your doctor about vaccinations or if you've had Hep B, as it could come back. A common side effect of Ocrevus is infusion reactions, and some may require hospitalization. It can increase your risk of infections, which can be serious and may decrease certain types of immunoglobulins. While PML was not reported in clinical trials, it could happen. An increased risk of cancer, including breast cancer, may exist.
Dear MS,
Of these.
All right, welcome back, and thank you all for joining us on this fine Saturday morning. And a big thank you to everyone who has worked so hard behind the scenes to make this event possible today, especially Bethany Schreiber and Dr. Shin. So, as Dr. Shin mentioned, my name is David Pisville, and I am a research coordinator here in the Department of Neurology. Today, I will have the pleasure of sharing information about our clinical trials with you all. I will first give you a little background as to what a clinical trial is, how they are run, and I will end my presentation with a brief description on our enrolling studies here at Georgetown. So on this slide, I'd like to introduce you to our research team in Brady Bunch style, if I may add, by this picture here. And we're comprised of clinical trial coordinators like myself, 2 directors, and a student research assistant who we recently welcomed to the team. So in order to understand a clinical trial, I think it's important to know why they are being conducted. The reason being that researchers are looking for answers with the help of volunteers like you to learn about the efficacy of new therapies. And it's important to note that the drugs that we have today are all thanks to participants in clinical trials. Without the participants, there would be less data to learn from these studies. And so they would not be able to run. These studies also play an important role in improving healthcare because the results at the end of these studies help better understand conditions like MS and NMOSD. So how do you know if joining a study is the right decision for you or your loved one in that? First, we advise you to check that the study is intended for your specific condition and reference the guidelines of eligibility criteria. Every trial has unique guidelines for who can participate in a specific study so that researchers can understand the results of clinical trials and for the safety of the participants as well. So we refer to these guidelines as eligibility criteria. Typically, these characteristics are like age, gender, medical history, to just list a few. And here, it's also important to weigh out your options, the pros and the cons. I mentioned here 2 benefits of clinical trials, in my opinion. I think that it allows patients to get access to novel therapies that are not available as standard treatment. So I would consider that a benefit. And it also allows patients to participate in generating knowledge about the disease that can impact other patients' lives and the community. It is also important to note that participation in a clinical trial can add to your already full schedule. Depending on the study protocol, it may require additional on-site visits and require additional commitment on your end. So if you would want to learn more about a specific study or you believe you may qualify for one, please contact our site and we could arrange something for you to meet with the study doctor or study team to answer any questions you have. And we can actually be reached via email or phone, and I will share my contact info at the end of this presentation for enrollment opportunities and study-specific information on the Informed Consent Form, or ICF. And what the ICF is, it's a document that explains the purpose, procedures, potential risks and benefits of the trial. And I'd like to note that informed consent is a critical step in clinical trials. It is a process that helps patients make an informed decision about whether to participate in a study. So we actually encourage all patients to take the time to review this consent form with their care team, loved ones, any other support figures in their lives before making this decision. And we also like to emphasize the point that participation is completely voluntary and your personal medical information is also kept confidential at all times. So after completing the consent process, we proceed with screening you. Our team will schedule you to come on site for a screening visit to review your medical records, perform several health assessments such as EKG, blood work, etc., and complete a neurology exam and physical. And this is all to determine that the results match the study criteria. And I also wanted to note that it is okay if you do not meet the criteria for a study. That does not exclude you from pursuing other studies that might be a better fit for you. So once we confirm eligibility, we proceed with research visits according to the protocol. And during the study, we are sure to monitor your health and make note of any adverse effects experienced at any point and any changes to your health while receiving the study treatment. And this is done until your final evaluation at the end of the study. So within our team in the neurology department, we have about 60 ongoing studies. And of those 60, there are currently 8 MS studies that are currently enrolling and 1 NMOSD study that is currently enrolling. So I actually invite you to visit our website, not now, but maybe at another time, where you can stay up to date with our currently enrolling studies. And the website link is here. It's neurology.georgetown.edu/GUNCR. So Georgetown University Neurology Clinical Trials. I included a screenshot here. When this is the main page you'll see when you go to the website, you'll want to select MS and then, or NMOSD. And then the dropdown will show every study that is currently enrolling. We make sure to keep this up to date and the appropriate point of contact for that study. And what these hyperlinks take you to is the clinicaltrial.gov website, where you can find more study related details on each one of these. So now I'd like to differentiate the different types of studies that we have: interventional and observational studies. Interventional studies test a potential therapy. So participants are assigned to either a placebo or a drug, and these are used to determine the effectiveness of a potential therapy. So this is probably what most people have in mind when they think of clinical trials. But we also have an observational type trial, which is also known as a registry, where we enroll participants, and those participants are enrolled over time. So there is no treatment given, and they are used to learn about trends in disease progression. And I actually think that this is a great option for someone who may be a little bit hesitant about enrolling in an interventional study, but would still like to be involved in a trial. So I'll cover some more on this in a bit. I've compiled a simple diagram here to help categorize our studies for you. Here on the right, you'll see this is for multiple sclerosis. And I've divided it between primary progressive MS here on the right and relapse remitting here on the other side. So starting here with primary progressive, the first study we have, again, these are interventional, meaning that there is a study drug involved. Here we have OHAND. This is a double-blinded study, meaning that neither the study team nor the participant know which arm they are randomized to. Of course, this can be unblinded in the case of an emergency, but for the purposes of the study, we are blinded. And it looks to evaluate the efficacy and safety of ocrelizumab or Ocrevus compared to placebo, specifically focusing on the upper limit disability progression. The second study we have here for primary progressive study, or primary progressive MS, is the fenebrutinib study, another double-blinded trial, and it's evaluating the efficacy and safety of fenebrutinib. So all eligible participants will be randomized to either fenebrutinib or ocrelizumab. So those are the only two clinical trials we have currently enrolling for primary progressive. Now switching over to relapse remitting MS, the first one we have here is Gemini. We are very excited to get this study started, and we are currently enrolling. It's a randomized study. It's double-blinded again, comparing a newer type of MS therapy called a BTK inhibitor to Aubagio, which is an already approved MS therapy. So participants will be randomized into one of those medications. Next, Enlighten. Enlighten is a single-arm study, and it's open label, meaning that if you qualify for the study, then everyone in the study will be taking the same medication, the same study drug, which is Zeposia or ozanimod. And the study is looking to study the change in cognitive processing speed in patients treated with this medication. And finally, here we have Treat MS. Treat MS is a standard of care trial, so there's no study drug provided. The study is looking at early aggressive therapy approach and comparing it to the traditional approach with the purpose of learning more about the influences of risk of disability. So participants will be randomized into one of those arms for this study. And then if you look further down here, I broke it down for the NMO studies. We currently only have one enrolling study for NMOSD. It's a pediatric study, and it's called NMO 303, a trial for eculizumab infusions in pediatric patients with NMOSD. So I also would like to mention that this list is constantly changing, and we have several studies in the pipeline. And when they are open to enrollment, we update our website and we update this flow sheet as well. And you might even hear your providers talk about these studies and maybe consider you for, or mention it as an option for your therapy. So this is constantly changing. And now that we have reviewed all of the interventional studies, I will be focusing now on the observational studies. So again, these are not intervening with any study drugs. First here we have Verismo, which is observational, and we are looking at patients who are newly initiating an MS treatment. So participation does not require any additional study visits or assessments. We are just looking to gather information to further assess the long-term safety profile for these MS therapies. And then here, MS Link, the next study, is a very interesting program, actually. It's looking to collect health data through online surveys, well-being diaries, along with medical histories from participants, and compile all of those into a web-based participation portal. The program is being done to gather data across a more diverse group of people living with MS and to help researchers and develop a way for providers to see a more complete picture of the MS population and their patients. And last, but certainly not least, we have Experience. And that study is looking to enroll participants who are receiving Vumerity. Vumerity is an MS therapy, to further the study of safety, tolerability, and effectiveness. Now, as with the rest of the world, we were also forced to adjust to the adversities brought by COVID. And our mission was to continue to run our clinical trials and prioritize the safety and privacy of all participants. So I'd like to commend all the participants that were already enrolled in studies, the study sponsors, and each and every provider here today for their determination in continuing with the progression of research. So a big virtual round of applause for everyone. We truly appreciate all your efforts in continuing these clinical trials. So we learned that study protocols needed to be adjusted accordingly. And we actually increased the use of, we did this in several ways. The first, I would say, is by increasing the use of virtual visits when in-person visits were not possible. And we continue to be cautious of what visits are really necessary to have on site, but that was a change that we had to implement. We also started using home-based companies, which allowed for a home collection of safety assessments, such as safety labs, EKG and vitals, and some studies allowed for nurses to actually go on site to patients' homes to complete these, which could help limit the exposure of COVID to this patient group. And finally, we also found ways to do drug accountability and ship drug to patients when they were unable to be on site here at Georgetown. So in conclusion, I wanted to share this to demonstrate that your safety is always our priority, and we will do whatever is within our reach to help provide the best care we can and reduce the burden for participants and their caregivers whenever we can. So with that being said, I must say that one of my favorite aspects of working in research is getting to know each and every one of you and being a resource for better care. So please, please, please don't hesitate to contact me with any questions you may have about anything you heard today or any interesting clinical trials. My name again is David Pisville. My email is here. My work cell is here. And I will also be available during the Q&A session at the end of today's event if you have any questions from my presentation. So thank you again.
All right, awesome, David. Thank you for doing that. Some of you may remember Derek, who also presented a couple of years ago from the clinical trials team. And so it's a really amazing group of individuals. I would sort of add what I think was already said, that, you know, that there's really no MS or NMO therapy that we're able to offer patients that got here without the participation of people living with MS or NMO who volunteered for the clinical trials to help us figure out how to use them and whether they were effective or not. So we often talk about people living with MS as sort of warriors fighting MS, but I think people who volunteer for clinical trials do deserve also special kudos as sort of heroes that are helping move the field forward to, for everyone's benefit. But our next talk, actually, speaking of clinical trials, is Dr. Faria Amjad, who is the director of MS clinical trials here at Georgetown, but also wears many hats as assistant professor of neurology and as director of the MS Spasticity Clinic. She has a very special and unique skill set for managing people with spasticity. And she's super passionate about education and outreach. And that's why we wanted her to get a chance to tell us more about her initiative, MS 101. All right, Dr. Amjad.
All right, thank you, Dr. Shin, and good morning, everyone. It's really nice to see such a large turnout. It's always very encouraging to see that. I just wanted to thank Bethany for all the hard work that she put into making this program happen and all the other people that helped her as well. So I'm going to be very brief today. I just wanted to introduce a patient education series similar to what's happening today, but it's happening on a more regular basis rather than just one day. And we've named it MS 1-1, and I'm going to go ahead and try to share my screen. Just give me 1 second. Okay, and just get to my PowerPoint slide. All right. So I hope everyone can see my slides. And so we named it Knowledge is Power, and it is a virtual education program. We actually ran this for the past year. So we already have made several videos that are posted. And the idea behind this series is that we take a much deeper dive into multiple sclerosis and all the issues and problems that come with it. It's not just sort of a superficial overview of things. It's a much deeper dive into specific topics. So I'll give you an example. The first lecture we did was a deep dive into MS and the clinical course, the different types of courses associated with MS. Then there were other lectures. For instance, we had Dr. Sussman, who is a urologist at Georgetown, speak about bladder issues that patients with MS may experience. We had another lecture done by Kim Foster, who is our social worker and will be presenting today, going over some of the issues around disability applications and home health aides, et cetera. We had another issue, topic given by Dr. who discussed sensory deficits and neuropathic pain that we oftentimes see in MS. And so the topics are, we're just focusing on one topic at a time. It's a deep dive. The lectures are pre-recorded. So the lecture itself is only about 40 to 45 minutes, but after that, there is a live Q&A session similar to what will be done today, where the presenter can answer your questions in live time. The lectures that have already been done are posted here. Here's the website. And the main sponsor of this program, actually the only sponsor of this program, was Biogen. So we're very thankful for their support. We hope to bring you even more lectures beginning next year. Kim and I will be working closely on this project. And we hope that you attend. You will probably be notified of each lecture, just like you were notified for this education day via email through Constant Contact. So thank you, everyone, and enjoy the rest of the day.
All right. So as Dr. Amjad mentioned, actually the recorded sessions, and they were monthly, there's a library of them that are available online. So if you go to the main Georgetown website, later on, we'll put the link up again. You might want to check those out as they accumulate. And, again, things are changing so rapidly in the field, having these sorts of educational programs are so important. So our next session is we have basically a guest lecture. So Dr. Jeffrey Wilkin is joining us from Neuropsychology Associates of Fairfax. And Dr. Wilkin actually hasn't a collaborative appointment with Georgetown University, but is part of a large group in Fairfax. And whenever I'm looking for someone to do cognitive testing, I always think of their group. So Dr. Wilkins is going to share his insights on cognition in MS, such an important topic. Thank you so much for joining us. Oh, I should also add one more thing, because Dr. Wilkin will have to, won't be able to stay for until the very end of this program. We're going to allow Q&A for him right after he speaks. So he's going to speak, and if while he's speaking you want to enter questions into Q&A, we're going to let him answer those questions right after this talk. But for everyone else, if you can just add the Q&A, we'll tackle them later. Okay, thanks, Dr. Wilkin.
Thank you. It's a pleasure to be invited to this forum today and to the discussion today, and I really do appreciate the opportunity to talk to everybody about I think a pretty important topic in MS, which is cognitive issues, cognitive dysfunction. And yeah, I appreciate that, Bob, to have a chance. I have something I need to get to with my kids this afternoon to drive one of them basically across part of the Mid-Atlantic, unfortunately, because I got them into travel hockey somehow. All right, so that's my problem, but thanks for allowing me to answer some questions right after. So I'm going to share my screen right now and get my slide presentation up. And let's see, here we are. All right, and so let me just get this started. Let's see. All right. Okay, so what I'm going to do is actually let me go. I'm trying to get my the slide presentation actually going, and I'm having a little bit of trouble figuring out how to do that, and I don't know why. Okay, well, I think what I'm going to have to do is I'm going to put Zoom down lower and see. Okay, oh, I see what I can do here. There we are. Okay. All right, there we are. Okay, thank you. Thanks for allowing for my delay there. Okay, so what I want to do is talk about cognition and MS from a perspective of both kind of my clinical practice, but also the research. I think it's important for people to kind of understand what research is out there, but it's also extremely important to understand kind of, you know, what it is that we see when we're just in the office, and what we see when we're working with patients and people with MS, and what the cognitive issues might do with respect to impact and implications on a person's life. And kind of primarily starting out with the idea that where it was used to be believed that MS did not affect cognition. When I first got into the field in the late 1990s, the thought was that MS didn't affect cognitive functioning, that it was a disease that affected motor and sensory functioning. But even starting in the mid to late 1990s, people were starting to do research, even in the early 90s. Didn't get into the kind of popular research until a little bit later, where people kind of understood it and read about it. But we started to realize that, in fact, if you have MS, the chance that you're going to have something going on that relates to your cognition, ability to understand things, one of those areas of thinking is much higher than we originally thought. So basically, it is that about 45 to 65% of people with MS will have some kind of difficulty as pertains to their cognitive functioning. That does not mean that they're going to be significantly cognitively impaired necessarily. It just means that there's going to be some kind of an issue with respect to cognition. And that issue, I'll get into just a few minutes about what that is, what types of areas are affected by MS, and what types of things we need to be thinking about. But what we're also realizing is, so about 45 to 65%, it's about half the people with MS, maybe a little bit more. We also know that just like with MS's physical issues, the degree, the pattern of cognitive involvement or cognitive difficulty is variable. Some people will have very little of that 45 to 65%. Some people have very little cognitive problem going on. Some people have a little bit more, or maybe some people a little bit more than that. It depends. And that's why we're going to be, as neuropsychologists, what I do is we look at people, we have them come to our office and do some testing, which I can describe in a few minutes as well. Now, the issue is that the cognitive problems with MS basically are the thing that really does have a major impact on a person's ability to function. These days, when I first got into MS, if people were to come into my office, a person with MS would come to my office, often they'll come in a scooter or a wheelchair, and that still happens. But with the medications out there, we're seeing a lot more people who you wouldn't even know had MS unless you talk to them, because they're doing a little better with respect to mobility. Perhaps they can walk without maybe the scooter. But what we're still, but what we're starting to figure out is that as those improvements are there physically, and maybe the medications are helping with cognition, but we still have those cognitive issues as well. You might have a person who looks like they can do pretty much anything because they're being treated. Maybe they have some mild physical or sensory issues with their treatment, but there's still some cognitive issues. And those are the things that are limiting a person's ability to work, to socialize, to maybe go to school. They might be the things that are affecting somebody's functioning at home. And the important thing is that they're referred to as invisible symptoms, these cognitive issues, because people can't see them unless you delve a little beneath the surface. And what we're realizing over time is that these are the symptoms that really are getting in a person's way in terms of ability to function in various environments. And if you look at the actual research, this statistic up here is actually a very kind of important one. If you look at the issue of whether a person is able to work or not, some of the earlier research on this will show that basically about 16% of MS patients who are just physically disabled, maybe there's something, no cognitive disability, just physical disability, which not really a just, I mean, it's an important thing, but if that's what you're thinking about in terms of employment, only about 16% of those people are not working. If you add in the cognitive issues, that brings it up to almost 50%. So I would guess that this study was done a few years back. So I would guess that if you did more, as we're doing more work on this, I'm starting to look more into employment issues with MS, that we're seeing probably a bit higher, even that there's more unemployment, more disability with respect to MS related, with respect to the problems that we see in the workplace. We're probably seeing more and more of the cognitive issues being a bigger problem than anything else with respect to MS related symptomatology. So we know that basically, if we have a person that comes in our office and they're having some cognitive issues and they're attempting to work, this is something we need to focus on. We need to understand what their cognitive issues are, how bad they are, how much they can be accounted for also by different treatments, which I'll talk about as we go along. And those are things we really need to focus on if we want to keep somebody within the workplace. And that's what, when people come into me, adults who are working and not at school, that's one of their biggest concerns. How do I stay there? How do I stay at work? How do I make sure that I'm going to function okay, not get fired? I mean, this day and age with disability, with the ADA, we shouldn't have people getting fired for disabilities, but it's still a big concern of people. They get worried about it, and we might need to actually send them in the direction of an employment lawyer so that they can understand their rights and as per the ADA, so that they can keep their job, maybe with some accommodations, things like that. We also know that cognitive dysfunction will affect a person's ability to complete activities of daily living. It makes it harder for people to, if somebody has some significant cognitive impairment and they have MS, they may have more trouble with remembering to take medications, remembering to do important things that affect their ability to manage their disease, their illness. Might be exercise, might be having trouble remembering or keeping up with how to do various things that are required for a person's functioning. We also know that decreased ability to engage in social interactions is another thing that we sometimes see when people have some cognitive problems. And that actually is something that people will come to my office all the time with MS, and they'll say to me, well, one of the things that I'm noticing is that I'm not socializing as much because I'm embarrassed. I'm losing my focus sometimes, or I'm not remembering things. So rather than be embarrassed, I'm just not going to do it. And unfortunately, that's one of the things that can be most dangerous with MS, because you start to retract from social situations or doing things that you like to do because of the cognitive issues, and that really makes you at risk for depression. And because we need to socialize, we need to be in activities. We've all seen this during COVID. I can't tell you how many people have come to my office, MS or no MS, throughout COVID, and talked about the depression factor because they are alone. They are not with other people and doing the things they used to do. Simple things like eating out at a restaurant, which we always have taken for granted, and we're not able to do it anymore. And it feels like something's been taken from us because we like to be around other people. And so if you have MS and you're having cognitive problems and you're withdrawing, the risk for depression is there. And I'll talk about that a little more. And that's the psychopathology, is depression and other issues, mental health issues that are very, very tied into cognition. Cognition and psychopathology are very correlated with each other, and one kind of drives the other. How do you know if there's an issue with cognition? So this is the kind of thing where you wonder, people say to me, well, I haven't gotten a neuropsych evaluation yet. My neurologist, does 50,000 different things with me in the office, but it's not possible to do a full cognitive screening along with all those things that they have to check for my MS. So how do I know? How do I know if there's something going on? Unfortunately, one of the things that we've learned about in the research is it's very hard for a person to predict his or her own cognitive functioning. If somebody were to say to you, how's your cognition? Your answer is not always going to be accurate, because it's very hard for people to know whether they're having cognitive problems by just kind of thinking about it. Let's see, how am I doing with my memory? People don't do a very good job at predicting how well they would do on, say, a formal neuropsych evaluation. What we found out, though, is that if you talk to people around you, the people that are helping to care for you, or your family members or friends, they do a pretty good job at kind of predicting that. They may be able to say, yeah, I've noticed that you're having trouble with this or having trouble with that. And so if you're hearing that from people pretty often, that's something that you want to take into account when you're talking to the neurologist who's taking care of you in terms of the cognitive issues. You also may want to, when you're thinking about how you're doing in your own, how's it going at home with your activities of daily living? How's it going at work or at school? And if you're having some problems with those activities, rather than thinking about maybe it's just that I'm not trying hard enough, or rather than thinking maybe it's just that I'm just not into it right now, you might be really picking up on something, or people around you, when they talk to you, might be picking up on something that's going on that you didn't even realize. So that's what I say here, some of the bullet points for how do I know that there's a cognitive issue or not? Well, everybody has one of these things happen once in a while. But if these things start to pile up, if your spouse, your coworkers, kids keep on saying, hey, you're not remembering the things we talked about, or you're noticing that, you used to have to write some things down, but now you have to write everything down because you're just not remembering things, or you're making mistakes like double paying bills or losing things all the time. These are things, again, if this happened to you once in a while, it happens. These are things that happen. As we get older, they happen even more. Having trouble finding words, things like used to be able to multitask, but now you're not able to multitask so much anymore. Background noise and things like that are making you very confused. If that's starting to pile up, you're hearing it from other people, you're noticing it more, you're hearing about it at work. Those are the kind of things that might make you start to get keyed into the possibility that something's going on with respect to your cognition. Now, there's also other things. I said that psychopathology or mental health issues are extremely tied into cognitive dysfunction with MS. So especially things like this, where not just depression, I'm going to talk about depression and stress in a minute, but my mood is up and down, these very, very big fluctuations in mood or kind of affect that is kind of very different than it used to be. People are noticing a change in your personality, things like that are noticed, where they're not just like sadness, but just changes in personality and kind of this kind of fluctuations in mood. These are things that are very predictive, we found out, of cognitive issues in MS. So if people are noticing that more, that might be something that you might want to pay attention to in terms of like whether you want to talk to your doc about it and figure out maybe, hey, there's something going on. What areas of cognitive functioning are affected by MS? It could be anything and it can be nothing, as I was talking about before. If you're one of those people that has MS that is fortunate and doesn't have cognition affected at all, that's great. I mean, that's, as I said, that could be up to 30, 40, maybe even 50% of people with MS. But for other people with MS, you have an area of cognitive dysfunction. As you know, learning about MS, so sometimes people with MS will have different physical symptoms. Sometimes, maybe numbness, maybe incontinence, maybe both. It's the same thing with MS and cognition. What we do, though, is this. If you look at these first three bullets here at the top of the slide here, one of the main areas affected, I would say, top one is the third bullet, actually. Information processing speed. If you think of MS, you have myelin sheath that is supposed to be an insulator around the axons or the wires in your brain, the connectors in your brain, and that if you think about it this way, where you have if some of the insulator goes away and the signals are not getting through those wires as efficiently as they should, then you're going to get a general inefficiency in your thinking. And so what gets affected often is the speed of thinking. You get a little bit slower thinking. You may know that you may notice that you're not picking up things as quickly, or you need people to slow down when they're talking to you because you can't think as fast as you used to. We also get problems with attention. Similar to thinking speed, it's an inefficiency where you're not able to focus quite as well, or as I mentioned before, sometimes you're not doing as good a job with multitasking or kind of keeping your focus on a couple of different things at once. And this is something that we notice a lot in MS if we're going to see a cognitive problem. Learning and memory, or learning and retrieval, I always talk about this a little bit separately because I really think it's important that people with MS understand that, because it's a fear thing. People with MS come into my office sometimes and will say, is this Alzheimer's disease? Is this the same thing? Is my memory shot like if I had dementia? And the answer for the majority of people with MS is no. The memory problems in MS are very different from the memory problems in Alzheimer's disease or other dementias. They have different cause, and they have a very different way of appearing. The thing that we see with, say, let's take a person with Alzheimer's disease. They come into my office. I might read them a list of words 5 times. At the end of the list, maybe at the end of the 5 trials, they'll give me maybe 10, 12 of the words. And then I give a delay, and then 20 minutes later say, can you read me the list back? And the common answer is, what list? I don't remember you reading me a list earlier. The reason is because with Alzheimer's disease or a lot of other types of dementias, we actually lose information. It decays, it goes away. We might learn something. Maybe you got 10 to 12 of those list items, but after a few minutes, they're gone, and the memory of even having done it is gone. With MS, for the most part, with some people with MS, with a very small percentage, you can get a memory problem that's fairly severe like that. But the majority, it's not like that. The MS doesn't usually cause that kind of memory problem. What we see in MS is we see an inefficiency of learning. So people have trouble learning after 5 trials of that list. Maybe they only learn 8 of them instead of 10 or 12 of the items. And then so you don't get as much information in. So later on, if I ask for that list back, you're going to say, oh yeah, that's right, you read me that list. What were those items? What were those items? I know them. And then you might not get as many of them back. You didn't learn as many in the first place, so maybe you feel like it's a memory problem. But look, if you didn't learn as many in the first place, it's not necessarily a memory problem not to remember all those list items. It means that you just didn't get them all in. Now, if you do have MS and you have a problem with memory, the issue would be then that maybe after 20 minutes, you can't give me those list items until I say, well, a few of them were fruits and vegetables. And then you'd be like, oh, that's right. It was an apple and a pear and broccoli. And so you maybe, you just need a little cueing. You just need to get a little bit of help to get that information back. So the difference between MS and dementia with memory is with MS, you have some trouble learning new information. Maybe you have trouble retrieving that information, but with cues, you can get it back. It's not the type of thing where dementia, where I can give you all the cues in the world and you're not going to get it. I can say, so there was some apple, there were some fruits and vegetables. A person with dementia is going to say, I still don't remember that you read me the list. So that's the difference. And so I always want to kind of focus a little bit, spend a little time on that memory problem in MS, because I really think that it's important people understand the difference between that and dementia, because I know it's a point of concern and fear among a lot of people with MS. And by the way, if you have MS, that doesn't mean you're going to have dementia. Some people say, well, because I have MS, am I also going to have Alzheimer's disease? They're separate illnesses. They don't, having one doesn't predict that you'll have the other. So just one thing that people do worry about when they come into my office as well. You also, with MS, you will see sometimes people with some visual, spatial, or perceptual problems, trouble kind of looking at visual things and understanding them. It's a little less common than these other top 3. Sometimes you get some language or verbal problems where you have trouble pulling up words. That comes with age. So you don't want to just assume that if you're having word finding problems that it's your MS, but it's the kind of thing we test when we see people in the office. And then there's executive functioning as well. the executive functioning is basically problem solving and reasoning and being able to kind of plan and understand the world on a very global level. And for some people with MS, a smaller percentage of these top three here, but for some people with MS, we have problems understanding, reasoning through things. And those are people then who are going to need some help potentially with planning, with managing illness and medications, and how to do the whole kind of full health kind of global managing of MS. When you have executive functioning problems, that can be hard, and those are times in which people will need some help. I'm going to talk about this last bullet more extensively here down the psychological stuff. So I'll move on to the next slide just in the interest of time. Now, the MS cognitive function, the issues related to MS and cognition are multifactorial. What does that mean? If somebody comes into my office and I only look at their cognitive functioning, I'm making a mistake, because that means I'm missing some very important issues. What might I be missing? Well, there are intercorrelations or correlations between cognitive dysfunction and many other areas of functioning for a person. What other areas do those include? One of the main ones is fatigue. Fatigue is probably the most common symptom of MS. And people with MS who have fatigue and have cognitive problems are going to have worse cognitive problems than if they didn't have fatigue. So fatigue is one of these things that reduces your stamina, and it doesn't reduce just your physical stamina, but it reduces your stamina with respect to your cognition. So you may not be able to stay on something that you're working on that's cognitively challenging as long because you're tired. And fatigue also can make your attention problems, if you have them with MS, worse. Psychological issues are another thing: depression and anxiety and stress. And I'll talk about those. I'm going to get into that just a little bit deeper in a minute, but we need to consider that. What I always tell people is this: fatigue and psychiatric distress are the enemies of cognition. So if you have MS and say we tested you cognitively and you were totally fine, you have no cognitive problems, if you're tired, stressed out, depressed, you'll still have cognitive problems, even because even though the MS isn't causing them, those things will cause them. Now, if you have MS-related cognitive impairment and then you're also fatigued, stressed out, tired, anxious, then your cognitive problems will be worse. So that's something that you need to consider. And so it's a multifactorial issue with MS in terms of looking at those various factors, as well as looking at cognition. So when we do studies of cognition, I'm involved in a lot of research on MS and cognition, we always measure fatigue. We always measure mood and stress and anxiety, because we need to know about that in order to understand the cognitive issues more. Now, how do you measure? Let me just talk to you. I'm not going to talk much about this. There are multiple assessments to be able to measure cognition. I bring this up just because you might see them if you ever look at the MS literature, but there are short tests that we use in research called like a BICAMS. There's a screening battery that was produced by Steve Rayo. Who was one of the neuropsychologists that started looking at MS. There's an MS, something called the MS functional composite, which is, it has some physical measures, but it also includes a cognitive measure. Sometimes we'll use computerized screening batteries. If your neurologist sends you to us, we'll put you through maybe a 3 to 5 hour neuropsych evaluation. This is the kind of thing, though, that we can break up into different days. We give you breaks, we get you through it. Usually insurance will cover it, but it's something that is hard to go through, but it can give us great information in terms of school and work recommendations and accommodations and things. Do you have cognitive problems, or are is the cognitive impairment that you're thinking about just due to your MS? Just due to your stress, your fatigue, that kind of thing. That's one of the things we also look at: psychiatric versus cognitive, and how to address either or both of those. And then in your actual, now these are things we do in our office. In your actual neurologist's office, one thing I want to just point out is you're not going to do full batteries like this. You might do some short screens for cognition. One is called the SDMT. I don't have the time to describe it now, but it's a very short little test that your neurologist may be doing with you as you're going through kind of your general MS evaluation. So now I talked a little about this. I'm running out of time and I don't want to go too far into this, but it's just that this slide here I kind of mentioned much earlier, but there is an increased incidence of stress, of depression, of anxiety in MS. It's common to have a chronic illness cause stress and cause a reaction to that stress, and that reaction can be psychological. Now, what we also know is that though the disease process itself does put us at increased risk if we have MS for depression, just as part of the disease process, not even as a reaction. We also see more of what we call bipolar disorder, which is kind of mood fluctuations, We see something we call pseudobulbar affect, which is kind of changes in mood that are a little maybe not appropriate for a situation. You might laugh a lot or cry a lot when nothing's going on that would cause that. These are things we sometimes see in MS. As I mentioned, stress. And the reason I bring all this up is because there is a kind of a hypothesis about psychoneuroimmunology, basically being that there is a strong relationship between stress, between psychiatric illness and then your physical illness, and that the more stress you have, the more that your psychiatric illness is untreated, the more likely it is that you'll have exacerbations, the more likely it is you'll have cognitive problems. So I really kind of bring this up as a way to say, if you're dealing with MS, you have cognitive problems with your MS, you go into the neuropsychologist or you're dealing with your neurologist and they say, look, part of this is cognitive, but part of this is also psychiatric. You need to get these things treated. Don't take that lightly. You need to actually really take care of the psychiatric issues associated with MS in order to help with your cognitive issues, in order to help with the disease process itself. With respect to cognition, there are pharmacologic interventions. We are looking at how the disease-modifying treatments help with respect to cognitive functioning in MS. We don't have all the answers there, but the thought that I always have is the better, if a medication is helping to reduce atrophy, to treat your MS in various other ways, it probably is also helping with cognition. We just need to look a little bit more into that. Sometimes your doctors will give you adjunctive cognitive medications. They may give you a stimulant or something that will help you focus your attention. That is very personal to you and your doctor. There's no approved medication for MS-related cognitive dysfunction with respect to extra medications, but sometimes people will use some of those to help with fatigue, to help, and also to treat psychiatric conditions. You might treat a psychiatric condition and find that you're doing better with respect to cognition, because as I said, psychiatric affects cognition. And then finally, and I'm aware of my time, so I'm going to kind of do this real quick, is cognitive rehabilitation. We're learning more that we can, and we're doing some studies on this right now, is that we can send people with MS to a cognitive rehab specialist. Often this is a speech language therapist, and we can do some cognitive rehab, which is helping people kind of sit down with somebody and learn different ways of managing cognitive problems. At home, we also we're learning more about brain training. These apps that can train your brain to help you do things that you're having trouble with. So maybe attention training or things like that. And we're learning more and more about these things being helpful. And the idea is that there are two basically ways of looking at cognitive rehab, which is restoration, which is the brain training, or kind of trying to maybe reestablish some connections in the brain. We can't get new neurons, but maybe we can reestablish connections for the neurons that are already there. And there's an entire lecture I give on this that shows some really nice slides looking at functional imaging and ways of looking at whether we can reestablish. And then there's compensation with rehab, which is what I was mentioning, where you sit down with a cognitive rehab specialist and they actually give you workarounds, ways to do things a little better, ways to manage your behavioral issues, or your cognitive issues with behavioral changes. And so what I'd like to see normally in a cog rehab program is treatment that encompasses both restoration and ways to compensate. And I think on that, and I'm aware that I don't want to overstep my time by too much. I will stop. And I think Dr. Shin had mentioned that I would take some questions right now if anybody has any.
Yeah, absolutely. So questions have been coming in. Someone put a question in the chat. We'd like it to be in the Q&A if possible. But first, a comment from one of the listeners. Dr. Wilkin, this is great. You hit all the points I experienced as a caregiver. Where were you 25 years ago? Please increase your presence on this topic. So
thank you very much. I really appreciate that.
Yeah. There are a couple of questions that are a little bit similar. Somebody asked, is it a myth that memory dysfunction comes with age? And then somebody else asked if there's any research on aging MS patients and cognitive difficulties.
So no, it is not a myth that memory problems come with age, but I wouldn't call it dysfunction. What happens with age is that our memories are not as good as they used to be. There's a kind of a trade-off with age. You gain wisdom and knowledge about the world as we get older. So we do a better job at understanding planning. We see this with our teenage kids where they can't plan we try to get them to plan and they can't. And we try and we say, well, we know how to plan because we have experience. But what we trade off there is speed of thinking and memory a bit and word finding. We're not quite as efficient as we used to be. When we do neuropsych testing, we always compare a person to people of their same age because because we know that there's a change over time. That is not dysfunction, though. That is just normal. We just lose a little bit of that over time. We get less efficient with memory and with speed of thinking. That's normal. If we start to see abnormal is when we start to see that with their activities of daily living. That's when we think of it as a true problem that is more than just, repeat that part of it. I think it was about aging with MS. But if I'm getting the question correctly, is there a correlation between memory problems, I think, if I'm remembering it correctly, and MS as we get older? And if I'm getting that question wrong, I apologize. But there's not necessarily a correlation between memory problems and MS as we age. There's as we get older, we will see, as I mentioned, those problems with memory, the inefficiencies. But just because you have MS doesn't mean that that's going to happen to you any worse than it would if you were getting older just normally. Everybody's different. You could have MS and have the genes that would give you some mild cognitive impairment or dementia, but that would be separate again from your MS. It's not the same thing. So MS doesn't just because it's MS doesn't mean that you're going to have the cognitive impairment.
All right, and then a couple more questions. I think general. One was a question, is IQ testing helpful? And then another kind of separate question would be, ginkgo biloba has been recognized as helpful for cognition. Would you recommend it?
So, okay, IQ testing first. IQ testing is not helpful at all for any reason. I mean, it's an antiquated concept to test somebody's intelligence quotient. Everybody has different kinds of intelligence. When we do neuropsych testing, we use the tests that look at IQ just because those tests have a whole variety of different subtests that let us look at all different areas of cognition. But I do not come up with an IQ number at the end. IQ testing, how do you get one number that's going to basically say this is a person's intellect? So what we do instead is we look at all different areas of cognitive functioning. If you came into my office for testing, IQ is the least important thing. What I care about is how are you with all these different areas of attention, of reasoning, of memory, of speed of thinking. Those are the kinds of things that we're going to look at and we're going to think about. So that's different from IQ testing. We're really doing more of a cognitive testing, thinking testing. Ginkgo biloba and other supplements, the problem with them is that we just don't get great research studies about them. We have anecdotal evidence, or people will say that they're helpful with respect to cognition. We don't know for sure because there aren't a lot of good studies for that or for any other supplement like that. The studies aren't out there. So what I always recommend to my patients is this: if you're going to take a supplement and it's one that's supposed to help cognition, first of all, don't break the bank doing it. But second, just talk to your doctor and make sure that it doesn't have a negative impact on MS or having some kind of a bad interaction with the medications you're already taking. Some supplements are actually immunosuppressant or immuno, or they'll fire up your immune system. So you just want to make sure that you're talking to your doctor, making sure it's okay to take that. And then if that's what you want to take, if that's what you're seeing in the kind of things you're reading, that this might be helpful, then as long as your doctor's okay with it. The problem is we just don't know how much of a help it will be because the research is not there.
All right, and I know you have to go, but I have one more question that I wanted to ask. Somebody said, I have a lot of these symptoms. Am I a good candidate for neuropsychological testing? And I think there are other questions about, basically people listening saying, should I get this testing? So what would you say to them?
Well, in the perfect world, my belief is, as a neuropsychologist, as a person who studies cognition with MS, it would be great to have a baseline with everybody. But we're not in a perfect world, and insurance doesn't necessarily, they're not going to just say, okay, we want a baseline. They'll cover it only when you're having problems. So I would say this: if you're doing screening where you're going to a neurologist and you do a single-digit modalities test or an SDMT every time, and that score starts to go down, then it's a really good time to get a referral to a neuropsychologist. If you're not doing screenings like that with your neurologist, because it does take a little bit of extra time, the way to know is if you're starting to have functional problems in your life, if you're starting to not do as well at school or at home or at work, and you're starting to notice that people are saying to you, things are not going that great anymore. You're having these troubles, and I don't understand what's happening or what's going on. That's the time in which I would think you'd want to talk to your neurologist, get yourself a referral for neuropsychological evaluation, because then we can look at, is there truly a cognitive problem or not? Is there truly something going on that we can address with the treatment, with accommodations, or whatever it might be. And I think, by the way, one thing I'll also say is that somebody was saying, what causes the cognitive problems in MS? I saw one of the questions. We don't know the answer to that. We can see on MRI that if there's more atrophy, especially in the thalamus or central parts of the brain, that we're going to have a more likely problem with respect to MS and cognition. But it's probably the things that cause the cognitive problems with MS are probably very similar to things that cause any of the physical issues with MS, as well as the whole kind of combination of the things that go on in the disease process. But we don't know for sure why this person will have a cognitive problem or that person won't.
All right. Well, to be honest, there were even more questions that we couldn't get to because I think it's a really important topic. And thank you so much for presenting. So we'll let you go. Have a safe trip. Travel hockey is certainly a huge time commitment for any.
Oh my God. Yeah, a little too much. But thank you so much. And I really appreciate the chance to talk to everybody. And thank you for inviting me.
Absolutely. All right. All right. So for our next session, we'll push back just by about 5 or 10 minutes to make sure that Deb Riley gets enough time for her session. And once again, we're fortunate to have her with us for a session on dance and MS, which I would say the movement portion of these patient education days has always really been a highlight, I think, for everyone. So thanks again for joining us, Ms. Riley.
Thank you so much for inviting me. I'm so pleased to be here. I'm just making an adjustment. And you could take the slide down, please, and I will share my screen. Thank you. Just a moment, everybody, while I make an adjustment to share my screen. Pause for a moment. I'm going to be sharing my music. And please, anybody on the presentation team that would like to jump in, if you cannot hear me at any point. Welcome, welcome. Thank you for the introduction. I'm Deborah Riley, and I teach movement for MS through the Arts and Humanities program at Georgetown University Hospital. I want to thank special thanks to Dr. Tornatori, Dr. Shin, and our research nurse, Erica Mitchell, for supporting this program so that it can be free to all of you. I hope you'll join. What I'm going to do is today we're going to do some gentle movement, and then we're going to do a rhythmic fun movement together. We are able to offer this through the direction of Julia Langley, the director of the Arts and Humanities program. And if you have an opportunity to check out our page, there are other classes that you might be interested in: gentle yoga, drawing, and all kinds of things, writing, that we offer. So they are all free. And you can find them at the beginning of the year in January. So just a moment before we start, I've really enjoyed all the information today, and I would say that dance is a really great strategy for well-being of your body, mind, and spirit. And of all the things that have been touched on today, dance has the ability to work with cognition. It has the ability to, of course, work with physical movement and also community. So that is a really very important aspect of, I'm going to turn up my volume. I see that someone couldn't hear me. It's a very important aspect of dance in our group of people, that forming of community and the enjoyment of being together with our common background. If you come to our group, I think you will see yourself represented in the group. We have men and women. We have different ethnic and racial backgrounds. And please come and give us a try. So to arrive today, I'm going to move back away from you a little bit. And let's yawn and stretch. Just yawn and stretch in any way that's comfortable for you. I want to make sure. Arrive in your body. Good. And I'm going to stay seated, but some of you may want to join standing. I encourage everyone in our class, and I encourage you today, to dance and make choices and move in a way that's comfortable and safe for you. We always do all kinds of variations on movement so that you can find your place and your dance today. So start by just a slow rocking across your pelvis. I'm holding onto my chair. I'm just shifting my weight, and I'm feeling weight in one hip, and then I'm feeling weight in the other. We're just going to anchor and feel our feet connected to the earth. So in your mind, connect your feet to the earth as you do this. Nice. Come back and just settle your body, relax your shoulders. Let's breathe together. Let's inhale. Slow exhale. Relax your shoulders. Let the hands land on your legs. Inhale. Soft movement of the hands. Exhale. Let's do that again. Arriving in your breath. Inhale. Exhale. One more time. Inhaling. Feel the anchor to the earth. And exhale. Nice. I'm going to put on some movement, some music. And it's going to be a little bit in the background. I'm reaching down to turn that music on right now. Let's start with our shoulders. Gentle circling of your shoulders. Forward, up, around, and back. In a way that's comfortable to you. No straining, no pain. Just really easy movement in your shoulders. Let's do one more. And let's take one hand, and as if you're reaching into the sleeve of a coat that's going up, stop at the place that's comfortable for you and wiggle your fingers at the end of that coat sleeve. Anchor in the same hip and just breathe and open this side of your body. Let's bring that arm down and go to the other side, as if your hand is slowly going into a sleeve of a coat, and you're going to wiggle your fingers out the other end. Anchor in that same hip, and breathe. Nice side body opening. Let's bring that elbow down, and let's do this 4 times. We're going to breathe in as if we're lifting clouds in our hands. Breathe out, hands down, and let your head bow over. I'm going to get a little bigger each time. Breathe in, lift the clouds a little bit higher. Breathe out, palms to the floor. Soften your head, look down. Here we go again. Breathe in. I'm going to go a little bit higher, sending my clouds up. Exhale, arms down. Let the head softly release. Last time. Inhale. Feel your feet and your anchor to your chair, and exhale, arms down. Release your head softly over and come up. Let's stretch our hand. You might have your wrist on your leg. I'm pulling my fingers back, or you might have your hand in front of you. Imagine that you have a glowing light shining out in front of you from your palm. Breathe in. Let's go to the other hand. Again, it might be balanced on your leg. It might be out in front of you. I'm giving a little resistance, pulling my fingers back. Now that shine is opening this palm directly out in front of you. Nice. Take the backs of your palms and reach into your legs. And I'm giving a little bit of pressure by leaning into my hands. Find what's comfortable to stretch your wrists in the other direction. Nice. I'm going to hold my chair, you could lift your heel off the floor and do little circles, or you could take the foot in front of you and just do slow circles of your toes in space. I'm just going to lift my foot a little bit. Draw circles either with your heel or your toe. Try to sit upright with ease. Change direction with your circling. What we want to do is just get a little movement in our toes, our foot, our ankle. Let's bring that foot down and change to the other side, either leaving the toes on the floor and circling your ankle, or just lifting your foot a little bit off the floor, circling from your toes. Relax your shoulders. I'm toning in my low belly to give a little support for my seated posture. Let's reverse, go the other direction with your circling toes and feel what's happening in your foot. Nice. Good. Hold on to the chair and heel on the floor or off the floor, and feel like there's a river, a flowing river down the back underneath your sit bone, your thigh, going through the calf and spilling out through the heel. Just giving a nice sense of putting your mind at the back of your leg and lower your foot. And let's change to the other side. Heel on the floor, pulling the toes back, or heel out in front of you. And imagining that flow of river water down the back of the leg, down the calf, out your heel. Breathe. Nice. Bring that down. Let's take our hands in front of us. Turn in your shoulders to face the corner and then the other corner. And we're just going to pretend we're a rotating fan, a physical fan, and just turn slowly. And my hands are in front of me. They just stay in front of me. Nice. Come back and stir your hands out away from you and back. I'm going to get a little bit bigger. I'm going to involve my shoulders and my body. I'm going to do it again, and I feel myself swirling through. Reverse directions. You could do a version with just your hands. You could get a little bigger and let your shoulders move with you. And you could get even a little bigger if that's safe and comfortable for you. Take your hand on your chair again and lift up and over. Just a little side bend. Pretend you're listening to the earth with that ear. If you like, you could hold your shoulder, or if you like, you could stretch your arm for a little bit bigger stretch on the side body. Breathe in, breathe out. And let's come up and change sides. I'm going to hold my chair as I lift up and over. I'm going to listen with this ear to the earth. You could touch your shoulder, or you could reach your arm if that's comfortable. Breathe in, breathe out. And let's come back and let's do a little shake of your hands like you're shaking water. Just shake water gently off your arms and wiggle around in your shoulders. See if you can wiggle your spine. See if you can wiggle your tail. Wiggle your hips a little bit. Just make a little joyful, effervescent movement there. And let's come back and let's do one breath. And exhale. Nice. Thank you. That's a sample of a little bit of our warm-up that we do together. And now we're going to do a little bit more quicker dance, a rhythmic dance, and I like to feel rhythm on my body. Again, do what is comfortable for you. And let's take a rhythm with our palms forward. We're going to have one palm forward, the other palm forward. Feel like you have those lights flashing on again that we practice. And palm and palm. And then we're going to open our elbows and we're going to take like a fountain up and open and back down and down. Let's do that again. Palm and palm and palm and palm, and fountain goes up and comes back down. It's as if you have water spraying between your hands. A second movement. Just pat your shoulders. I'm crisscrossing my arms to my front of my shoulders, or you could pat your lower arm. Pat, pat, legs, legs. Pat, pat, legs, legs. And then let's take one hand, the other hand, and I'm just doing a little flip and offer, and I'm looking in that direction. Do a tempo that's good for you. You could go here and here, and just one tap. Or you could go tap, 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 right and left and right and left. And I'm going to tap my heels. They're kind of bouncing with me, and look and look and look and look. Our third movement, bring your hands together again, and let's do our stir around and pulse to the corner. Stir around and pulse. I'm just taking my hands forward. Stir around and pulse, pulse, and stir around and pulse and pulse. Let's put on our music. Do as much or as little as you want to do. Mostly have fun. All right, here we go. Turn this down just a bit. All right, let's start with your own rhythm. Find a rhythm in your body. Find it in your elbows. Find it in your shoulders. How about in your hips? Find your rhythm. All right, let's start with our palm. Here we go. Fountain and down. Let's do that again. Rhythm and a whoosh. Let's do it 2 more times. And together, open. I like sending my energy, and I like receiving it back from you. have to bend over for my music. Very nice, everybody. Let's finish with a bow. We want to, dancers always bow to each other. It's an acknowledgement of thank you for showing up. Thank you for bringing your energy and your spirit and your creativity. And let's do a very elaborate bow. I'm going to take my arm slowly and open. I'm going to take my other arm slowly, very light. And I'm going to take both arms and bow. Let's do that again. Do your bow. This is my bow, a slow arm, and I'm looking. Just very smooth, easy, both arms. Thank you, everybody. Thank you very much for your dancing today. I'm going to share my screen so that you can see after I finish talking. So there's a phone number you can call to join our class. We have one more class next week, and then we start again mid-January. It's called Movement for MS, and you can contact the Arts and Humanities program. Again, thank you so much for joining me today and for coming to the conference and being a part of all this important information. Take care, everybody. I'm going to share my screen.
That was really great, Deb. Let's see if you can get that screen shared. There we go. That's awesome. Well, thank you so much for that. To be honest, it started out a little bit soft, but then you got that you got the music going, and that was a pretty good session. So, okay, so you see the Movement for MS sign up number there, 202-444-7228. So, and I will kind of remind people, I know a lot of people were asking other questions about information. I think after today, we'll have as much information as we can on the Georgetown MS Center website, which we'll post that link again before the end of the session. And just make sure that everyone can get connected and find out more about this program. You're actually getting some great feedback, great beat. And somebody else commented, I love the exercise and music. So I've been sitting on my butt for however many hours. So it was nice to kind of at least be able to rock and move around a little bit. So I definitely appreciate that. So we're going to take our break. We're just going to shift the schedule back ever so slightly. And so there'll be another video to watch. And again, I encourage you to visit with our supporters and our vendors on the exhibit hall. Bethany, I think if you agree, maybe we'll still give everyone a 15-minute break. And so we can plan to reconvene with Kimberly at 11:30, 11:35-ish, okay?
Um, my name is Emily, and I live with MS. On a good day, I am walking fine. I can do just about everything I want to do.
My dad's doing pretty well. He's still walking, he still works full time.
With my new infusion, I am having more better days than bad days.
My knees feel good. I can actually feel all 10 of my toes.
I haven't had any symptoms or episodes in a long time. I think the rate at which we're finding discoveries in MS is pretty astounding.
A generation or two ago, people had no treatment options to turn to. The medications have really changed the course.
When Jean was diagnosed, she had been an avid cyclist, biking 40 miles every single morning.
People call me Dash. That's my nickname, because how I move rather quickly.
Altogether, I served for about 12 years, from 1991 to 2003.
Married to the person of my dreams, feeling really stable. And then everything just got ripped out.
Within a couple of years of her diagnosis, she was wheelchair bound, and just a few years later, she was bed-bound quadriplegic.
The doctors told me they weren't sure if I'd be able to walk without a walker or walk anymore.
I couldn't run. It would just mess with me in my mind, like Dash couldn't run.
My mom also had MS. I can only hope that when it comes to my MS, that it does not impact me as much as it did her.
You cry because you mourn your former self.
I'm thinking about my body holding up every day for the rest of my life. And that sucks. It really sucks.
But we're resilient. We always have been. All these drugs that we have to slow down the progression of the disease is great, but what I would like to see in my lifetime is an actual cure.
We've really come a far way in such a short amount of time.
If we continue doing what we're doing, raising more money, supporting more research, we will find a cure.
Talk to us, reach out to us, listen, because the only way we can find a cure is with help from everybody.
We have to go on offense. We have to change the course of this.
And I don't think that's a lot to ask.
There's a lot more that we can do.
Well, I appreciate everybody's attention, and I want to thank you so much for listening.
Thanks for listening.
Thank you.
Thanks,
you
guys,
all.
so much
Thank
for
you
listening.
for listening.
My name is Emily, and
All right, for those of you who are online, we're just going to extend the break until 11:35, just to make sure everyone has a chance to, take a little break, get up and move around a little bit. So, so we are going to resume at 11:35. Okay, we're back. If we do this virtually again, I realize we need background music. So during our break, before and after, maybe we can borrow some of Deb's music because she has some pretty awesome rhythms there that we could play in the background. But so for our next session, we're going to be talking about support for loved ones and caregivers. And this is such a hugely important issue. Dr. T already mentioned Kimberly Foster had joined the Georgetown MS Center. It feels like you've been with us for a while, but I didn't realize it's been such a short time because she's really changed, kind of in a way, changed everything. Her outlook is fantastic. Her dedication to people living with MS and their families and caregivers, as well as her attention to wellness for us in the MS Center has really, it's just been such a pleasure to get to know Kim and work with her. So I'm excited for her to have this opportunity to get to know you guys a little bit better as well. So go ahead, Kim.
Good morning. 1 second here as I also manage the tech world. Okay, so thank you so much for being with us this year. It's really an honor and a privilege to join you today to talk about support for caregivers, loved ones, and I'm also going to add the words care partners to this. I just really love those words because it opens up the door to include more people in our lives. Some of you might have read the title of this session and thought, I don't need this information because of where I am or where my family's at in our life right now. But I hope that you'll stick with me as I see this presentation being applicable not only to people that are providing direct hands-on care to someone that they love, but also applicable to all of us as our families change and as we age in life as well. So let's jump in with a quote. And this quote is from former First, whoa, I apologize for that. This quote is from former First Lady Rosalind Carter. There are 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. This quote rings true for me because we're all human beings. We come into this world needing care, and we go out of this world needing care. And the fact that we care for each other in different ways all the time. We care for each other emotionally. We care for some people, we care for each other physically, for some of us, financially. Sometimes we provide spiritual care as well, among other things. And we provide care to people that we love, to our communities, and sometimes even to strangers. So in all the care that we provide to others, that can often evolve over time. And what I like to point out is what we all know, but that big life changes rarely happen in a vacuum, right? And a big life change may be the diagnosis of a chronic illness, such as MS, NMO, MOG, among other things, especially in our neuroimmunology clinic community. And so, yes, while this big change or this new diagnosis is happening to the person, that the person is living with the diagnosis, with the illness, again, it's not in that vacuum. So it has ripple effects to potentially people that we live with, our extended family, our friends, our social groups. Sometimes it impacts our careers. Sometimes it impacts other relationships and things that we do in the community. And that when these life changes happen, often there's a lack of adequate preparation for role changes. Again, that happens to so many things in our lives. Not only a new medical diagnosis, but think about when people start a new career and they've got to learn how to manage all those things, or when there's a new baby. And how many times have you heard a parent say, there's no handbook for this, right? Well, I need a handbook. I need to know how to do these things. But life doesn't come with that very often. And so it's trying to figure out any role changes that may have to happen, not only for the person, say, living with a chronic illness, but also for, again, their care partners and people that love them. And I'll use myself as an example in my life, in that chronic illness can lead to care partners taking on new roles or different roles. And in my life, my mother, who has since passed, was ill for several years. And not only did my father's role change, my role as an adult child changed as well. And some of those evolving roles for care partners, excuse me, might include some of these things. It's not an exhaustive list, but they might need to take on the role of being an advocate. Some people need help dealing with financial issues, asking the right questions about medical issues, about medications, about their career, anything else. Sometimes an advocate is working with insurance companies, an employer, a government agency to ensure that their loved one has access to care and benefits. Sometimes our roles can change into providing more nursing care and support. Sometimes that looks like going to doctor's appointments with someone that you love, remembering what happens at our appointments and being able to talk back around like, oh, this happened, this is what I remembered, this is what I took, these are things that we need to look up and explore more. Things such as monitoring symptoms, managing symptoms, and maybe monitoring and managing medications. There's the role of consoler, and I hope that everybody has someone in their life, a support person that listens and provides emotional support along the way. The role of helper is what I think that most people go to first when they think of a caregiver or a care partner, and thinking about those like hands-on day-to-day things that have to get done. And some of those are mundane life tasks like shopping, cooking, cleaning, pulling weeds, taking out the trash, picking up dry cleaning. Can also lead up to assisting with activities of daily care and hygiene, getting in and out of bed, getting dressed, taking medication, toileting, transportation to appointments, etc. There's also the role of safety guard. And for some care partners, they may have to step up looking for ways to keep their loved ones safe. Might need to keep an eye on everything from fall hazards to safe driving to medication management. And one of the last things that I'll talk about is the role of being a steward. And that can be the steward of, again, taking care of the home, taking more care of children, taking care of future planning, which can include long-term planning and supports that your loved one might need. It can also be being the steward of finances. Using an example from my life and my parents' life is that in my parents' relationship, my mother was the bill payer. She knew where all the money was. She paid all the bills. She knew how to do it. And as technology improved, she was doing most of that online, like many of us do now. My father had no idea. His job was to balance the checkbook on one Sunday a month in the afternoon. And then they reconciled things. And so when my mother's memory and cognitive abilities were decreasing, she noticed it. And thankfully, she started writing down all the websites and the passwords and when she had to pay the bills and how she paid the bills, whether it was through automatic with the bank or if she went through and paid it a different way. And so one of the roles that I took on was educator with my dad, to sit at the computer and go through all these steps and see what my mother did and how she did it, and putting it on his calendar so that he could take over as the steward of their finances. And something quirky that happened was he started writing checks to pay for all the bills in the beginning because it was just too much and trying to figure it out. And I'm just pleased to say that he has taken over the role. He does it online, and he's really successful at it. But that's just one of the ways that my family changed when we had to take on different roles. And that might be happening in your life as well. And I'll also say that we as individuals do not provide care to anyone in our lives in isolation from the other responsibilities that we have. As care partners, we are spouses, we are intimate partners, we are parents, we are children, we are employees, we are business owners, we're community members, etc. And so I like the imagery of juggling balls, right? Juggling all the roles that we have in life, all the tasks that we have to do, and trying to manage it. And under ideal circumstances, we're all, including care partners, able to balance all those responsibilities, right? We've got it. It's okay. And then maybe more things are added, more tasks, more responsibilities. So it's more things to juggle and try to do it successfully over time. And that can be overwhelming. I think things in our life, just with the regular balls that we juggle, can be overwhelming anyways. And so adding some more, even when we want to do it, we are grateful to do it, we are privileged to do it, it can still undermine some of the dimensions of our life. Maybe we have trouble with our own health. That's a big one for caregivers. Maybe it's a decline in work, decline in our relationships. Something else isn't getting done. The trash isn't getting taken out when it should, so it piles up. Laundry can pile up, right? And so it can be easy to lose oneself. And this can lead to caregiver or care partner burnout. Care partner burnout is a state of physical, emotional, and mental exhaustion. It can be accompanied by a change in attitude from positive and caring to sometimes negativity and feeling unconcerned or acting unconcerned. Why might this happen to care partners? Well, burnout usually happens when people don't get what they need, or that they're trying to do more than they're able to do. What might a care partner be experiencing if they're on their way to a burnout, or if they're smack in the middle of a burnout? Well, there's lots of things. This is a small list, but some things to be mindful of are withdrawal and isolation from family and friends, loss of interest in activities that they used to enjoy, feeling blue or depressed, feeling cranky, hopeless and helpless, increased anxiety, fear, frustration. There also might be a development of some physical symptoms. Some of those might include trouble sleeping, trouble with eating and hydrating, stomach aches, headaches, fatigue. There might be the misuse of alcohol, prescription drugs, or sleep medications. And when I talk about these red flags, I'm not talking about the person that's having a bad Tuesday, right? We all have that. It's like, I didn't get good sleep last night. I woke up, I'm hangry because I haven't eaten all day and I've had a bunch of caffeine and something at work didn't go right. I tripped over my kids' Legos. I've got whatever, these bills mounting up. And so I'm tired and I'm not my best today. What I'm looking at, I want people to think about is that if any of these things are happening to you and they're negatively impacting your day-to-day life for typically longer than 2 weeks, that's significant. And my suggestion to you, my hope to you, is that you will realize that, this is an issue for me and I need to talk to somebody. That could be your primary care doctor. It could be reaching out to people that you know, love, and trust that will support you. It could also be thinking of ways to take care of your mental health, such as a support group or counseling, which I'll talk about towards the end of the presentation, right? But if these things are happening, I encourage you to take some action steps. So what can you do as a care partner to take care of yourself? There are lots of things. And if we are at our best, we have more energy, more physical energy, more emotional energy to provide care and support to other people that we love, and also to our communities. But these are just a smattering of ideas that are probably not going to be new to you. What might be new is putting these things into practice, taking action. So I want to start with the image on the left. And if you are a friend of mine or a coworker or a patient or caregiver that I've talked to already, you've probably heard this or something very similar to this, which is take time for yourself every day. It's not being selfish, it's being healthy. Dr. Shin talked about how I try to encourage wellness with my team at Georgetown. And so these are things that I try to convey to them because it's so important, right? For all of us to be as healthy as we can be. But there's other things we can do. So one is to communicate, communicate, communicate. There's no such thing as mind reading. I wish there was, but there's not. So having honest and often calm and effective communication with your friends and your families can really be so important. It can be helpful. It can help us feel better. It can help us do better. And it can also often stop problems in their tracks, right? Just by talking about things and sharing thoughts about things that you need from your loved ones or your support systems. Do you need more affection? Do you need more intimacy? Do you need more love or being shown more love? Do you need better communication? Do you need hands-on help? Do you need respite? Whatever it might be. But being able to communicate your needs can really be important and empowering. But I'll also say that part of communication is also listening to the other person, listening to other people in your life, your loved ones, for what they need, and recognizing that, yes, these are things that we need to work on together. And how do we do that in the best way? Again, part of that is communication, planning things out, talking about it, taking actions. Another thing that can be really helpful and empowering is educating yourself, especially around the chronic illness that is now in your life, that your important person in your life is living with, is managing, is not managing, whatever that might look like. But reading books, reading articles, listening to podcasts, going to doctor's appointments if that's okay with your loved one, asking the doctor's questions, and often doing these things together with your loved one, right? So that you're both learning, you're both understanding, you're both gaining knowledge that can be helpful as you move forward. And the other thing is going to websites or agencies like the National MS Society that might have, or that will have, information that will have information on resources, on research, on support groups, on living with this, on taking care of yourself as a caregiver, and ways to advocate for your loved one and for finding money for research, finding money to provide direct care for people that are also living in this neuroimmunology community. And so information can be really powerful. And I think that information around chronic illness can also create a level of compassion for someone that you love. Okay, so there's more things to do. As a care partner, you can stay healthy. An interesting thing that I've realized is that we love the words self-care. But I was talking to a gentleman one day and he didn't roll his eyes at me, but I felt like in his head he was doing it. And he said, when you say self-care, Kim, I think that that's what women do. He said, my wife is really good at self-care, but men, like, we don't do self-care. Some men do. I'm not saying a generalization, but for him. And so I did some research and I came across the language of self-management. And I talked with him about it. He goes, I can get behind self-management. I get that. I understand that. That sounds very business-like. And I can understand what it might mean. So whether you call it self-care, whether you call it self-management, whatever it is, it's really taking care of yourself so that you can be the healthiest and you can be the best version of you with more energy, more mental energy, cognitive energy to take care of people that you love. And so what does that include? Well, that includes going to your own medical appointments, taking your own medication correctly, eating well, losing weight if you need to, decreasing alcohol and maybe some other substances. It can include reinforcing or increasing your support network. It includes assessing your own limits and your burnout level, managing your own mental health needs, which again, I'm going to talk about specifically, and also engaging in healthy things that make you happy. If you can see the part that says hobbies, the picture. And so that has lots of things on there, from video games to playing games, to being musical, to being creative with painting, with photography, with some healthy shopping, cooking, the exercise, any of those things that you get some joy out of. And I just want the caveat of healthy, safe things that you get joy out of. Those are important for your brain, for your body, and for your own mental health. I'll also highlight that there are 4 excellent ways to decrease stress and anxiety. And one of those things, the image with the brain in bed, is getting good sleep every night, doing the best that you can, an average of 7 to 9 hours. Another one on the opposite corner is the brain working out, and it says exercise is brain food. And that is so true, especially if you can get some cardio in there. I'm not asking or saying that everybody needs to run up a mountain at full speed and have your lungs be so powerfully working that you can't breathe. But if there's a way in whatever you're doing to get your heart rate up a little bit, to get some of those good endorphins, that good dopamine released in your brain, those good chemicals, that really helps your brain out tremendously. Another one is spending time in nature. It's lots of research that can show being in nature and even watching nature videos, like calming nature videos or videos of kittens and puppies, really can be really good ways to de-stress and to reduce anxiety. And the last one I'll talk about is meditation or deep breathing. And so in doing that, meditation can be really hard for people. It's really scary. But if you phrase it as deep breathing, and it's the slow, deep breaths in and slow breaths out. And doing that pattern, slow breaths in and slow breaths out. Lots of things can happen in your body when you do that. One, it can decrease your heart rate. And it also is tapping into that amygdala part where there's lots of emotions, especially anxiety and fear. And it's telling that amygdala, you can rest. It's okay. We're safe. We're going to calm down. And so that anxiety, some of that depressed mood, frustration can recede so that your frontal cortex, your thinking part of your brain, can kick back in and do higher level cognition. You get better memory, better problem solving skills, more language. And so really deep breathing or any type of meditation that you can add into your life or improve if you're already doing it, I really encourage you to do that because it's so good for your brain. And if you don't believe me, ask any of your neurology team and they will back me up. All right. Just another example is doing fun or calm things together with your loved one or someone that you're providing care for. And this can increase communication. This can release some good chemicals, again, some good dopamine. You can laugh. You can do some meditation together to ease anxiety and frustration. And it can also improve intimacy, which helps our relationships and helps us feel better. So even when we are doing the best that we can, we're juggling all the balls, or that, you know what, I'm not juggling all these balls really well. I'm not juggling it all. I need some help. I want to not get to burnout, or I'm burned out. I need some help. I need some assistance from someone. Then we get to this point. And I've heard many people, both persons living with a chronic illness and their care partners say, I don't want to be a burden. In my family, my mother had said that as well, and also my father as the care partner. He said that for a very long time. And it took a lot of conversation and support and encouragement to get my dad to the point of accepting some other help. I think it's the nature of life. Life is burdensome. Life is hard. Life can be difficult, but that we need each other. Remember the quote at the beginning of our time together. We come into this world needing care, and we go out of this world needing care. And in fact, most adults spend decades helping others and helping people in their community when they can. Think of your own life. Who have you helped? Who have you lightened the load for? Who have you supported emotionally, physically, spiritually, financially? And then think about, why is it hard to accept help when we've so freely given it to others? That's individual to every person, I'm not going to get into it today, but I challenge you to do some self-reflection on that. Why is it hard for us to accept help from other people? And I also love thinking about language and changing mindsets. And I love the idea that we get to care for each other versus we have to care for each other. And I've heard many people say, well, my partner or my parent or my child, they have to do these things for me because they're family. Honestly, no one has to do anything for us. It's all a choice. There's always a door out. And so even if we're doing things with a heavy heart or we're exhausted, we may not want to do it, we're still choosing to provide care, to provide support, to provide love to someone. And so shifting the language again to we get to care for each other versus we have to care for each other, I think can be really powerful to our relationships and also to our mental health. But honestly, a reality is sometimes we get overwhelmed, even when we have the best intentions or we have all the love in the world. Sometimes we just can't get it done. We need help because life is complicated. And I'll also point out, someone is probably saying it to themselves or saying it into the chat, that not everyone has an extensive network. Not everyone has positive or healthy relationships. And that is true. That is true in life. And so if you're that person, maybe you need help from an agency or whether that's like the MS Society or CERNA or something else, from a home health aides company, from visiting nurses, that exists. Yep. But for people that do have friends, children, a support network, parents, many of us, speaking for myself as an adult child, we do want to help you. We do want to support you to the best of our ability. And that sometimes it's a matter of letting people in. So who might provide supports to us? Before we get into that, I just want to remind people that support comes in different forms, such as physical support, emotional support, social support, spiritual support, financial support. And so that we often can't get all of those things in one person. That maybe we need to have some of these things come from other places. And so who might be available? If you have extended family, friends, neighbors, great. If you are part of a religious community that is supportive of you and that you gain strength from, social support such as sororities, fraternities, veterans groups, your knitting club, your running club, whatever it is. If you're a part of something, then there's probably a chance of getting support from that group of people. Many local departments of aging and or departments of disabilities have resources, have staff that might be helpful, have connections to other resources in the community. Sometimes they have financial help. Just depends on what you need. Sometimes they have social groups as well. So tapping into that and just exploring what resources they might have can be really helpful. Home health aid services. If you have Medicaid, that opens a lot of doors for you, or if you're able to pay out of pocket, Home health aid services can be very expensive. I acknowledge that that is a reality in our life. And so many families, probably many of you might not be able to afford that. But if you could, or you have the ability through your insurance, home health aid services can be really helpful. Also bigger agencies, right? So the National MS Society, MS Foundation, the Siegel Rare Neuroimmune Association, or CIRNA, also have lots of resources, lots of options for support. Sometimes they have financial ability to help people. An example is that the MS Society recently put in a ramp for someone that I worked with, got approval to pay for a dental crown that the person could not afford, and has done things like paid for a hearing aid, and also interesting things, right? Like exercise classes, or something like equine, or otherwise known as horse therapy. So there's definitely some options. And one of the last things that I'll talk about with this slide is the potential for crowdfunding programs such as GoFundMe. I don't know a lot about them, but it's a way of people donating to something that you might need. Recently, I heard of a patient who had friends who did a GoFundMe to help pay for hospital bills and transportation issues. And so I'll say anything about GoFundMe or any of these other platforms is do your research, read the fine print, understanding tax implications, and how that money needs to be collected and distributed. So do some due diligence if you want to go that route, but it can be helpful for many people. Lastly, I want to talk about emotional health. Taking care of your mental health needs is imperative to being healthy overall. This goes for persons living with a chronic illness, to care partners. It also goes to all of us as providers and people that we love and care for as well. And so there's different ways to take care of your emotional health. And one of the ways is participating in a support group. There's tons of support groups out there. There's different ways to find them. One is the National MS Society. There's the Siegel Rare Neuroimmune Association, or CIRNA. There's a local group called Speak MS, where I recently spoke, and you can contact Monica Proctor Wilson there. While she's local, there's also some people from around the nation that have joined, and I feel as though she told me some international people have joined that group. There's the Well Spouse organization. And then Facebook. Facebook has a ton of support groups at different levels and different expertise, right? Other options is individual counseling. I love individual counseling. I love the idea of a safe space for you to share what you want, to problem solve, to say what you need to say, with someone that doesn't have that emotional attachment to your life. You don't have to take care of them, right? So it can be a really great space for many people. Other options are couples counseling or family counseling. The point that I'd like you to take home is that you're not alone, or you don't have to be alone if you're open to other supports. And I hope that you'll take advantage of that before you need it. But if you're smack in the middle of it, headed to burnout, or are burned out, these are definitely places where I'd love for you to start. And so you survived. We've made it to the end. So I just want to thank you for listening, for joining. I want to thank you for taking care of yourselves and for taking care of others. I want to thank Bethany Schreiber and also the rest of the MedStar, Georgetown, MS, and neuroimmunology team for all that they do on a daily basis. It's really been a pleasure working within this special community, and I hope that everybody has a great weekend. And thank you so much.
All right, that was fantastic, Kim. Actually, I'm going to give you some instant feedback that somebody typed into the chat. Somebody wrote, "You are wonderful. Exactly what I need to hear and practice. This is a blessing for me. You have brought tears to my eyes." So I thought you needed to hear that. So we have a few minutes left for a little bit of Q&A, and I know people have been typing questions into the Q&A box, and we've got Dr. Tornatore stayed on for the entire 4-hour session so that you could help answer questions. And I think Bethany, we may not even need to necessarily share screen anymore. However you want to do it, maybe you can start throwing some questions out, because we only have about maybe 15 minutes or so before we wrap up.
Oh, wonderful. We had some great presentations today, and we also have some really great questions. So the first question I will direct towards Dr. Tornatore. So there is a patient who talked about a recent story about a gel being injected into a mouse that allowed them to regain walking ability. And could this be used in treating MS? So wanted to ask if there was any new data on remyelination that you're aware of, or any areas of interest.
Yes, so I'm aware of that paper, but rather than talk about that specifically, let's talk about repair in general, something that we have discussed at previous patient days. We didn't, not so much today, but that's okay. But I will tell you, number one, this is a very active area of investigation that last month at 2 of our big MS meetings was an active area that was discussed. And in particular, there was a study from the Cleveland Clinic, which I think is very, very interesting. So what they did is they took stem cells from patients themselves, right? So they took their own stem cells, they grew them up, so they took them out of their blood, they took them out, and then they took the stem cells and then put them in the spinal fluid with the idea that they were looking for those cells to repair the spinal cord and the brain. So it's not unlike what the group that put the gel in the spinal cord are trying to do. A little bit different, but the same idea that you're trying to put something close to where the injury is to get it to repair. And what the group at the Cleveland Clinic found is it's a little too early, for them to say that they saw, patients getting better or anything. But what they did notice, at least in the beginning stages, is that they were looking at markers in the spinal fluid for inflammation, as well as markers that would predict that there would be repair. And they actually found both, which was incredibly, incredibly interesting, because you can imagine that experiment or clinical trial could have been an absolute bust, where they just put things in the spinal fluid, but it couldn't. They could have seen inflammation or saw that those cells were potentially going to improve function of the spinal cord by allowing it to repair itself. There are so that's extremely exciting that that is the first step towards potentially getting patients beyond just controlling the inflammation, but also getting repair. And then there are a number of small molecules. We mean small molecules. We mean things that could be either pills or infusions that may directly result in repair of the nervous system by allowing the stem cells you already have in your brain and spine to recover and start to make new myelin and possibly new nerves. So I think this area is unbelievably interesting, We've gotten really, really good at shutting down inflammation in MS to a very significant degree. However, we haven't really cracked the nut yet on how to fix what's been broken. And these studies, particularly this year, really give me a lot of hope that in the not too distant future, really, we keep saying, 2 or 3 years, and as one of my favorite patients keeps telling me, Dr. T, 10 years ago, you were telling me it was 2 or 3 years. I'm like, yeah, I know. So we have to be realistic, but I really think the technology at this point is such that, and if these trials really come to fruition, really within 5 years, we're going to see this, and clinical trials for this will be ongoing well before then. So I'm very, very optimistic that within this decade, we really will see those first repairs happening. And I think all of us at the MS Center have seen this on a daily basis, where we have patients that that have aggressive disease. We treat them and we see them improve. And you can argue, well, that improvement is just from inflammation, but there's others that kind of surprise us with how well they do, and that they recover things a lot more than we would have expected just by bringing down inflammation. So I would, say to all of you, remain optimistic. I know MS can be tough. And there can be many dark days, as Kim was trying to give you tools, to work with that. But I remain very optimistic. Again, things are still like this gel. I don't know if that's going to be the one that pans out, but something will. So stay positive.
Thank you, Dr. Tornatore. Dr. Shin, I have a question for you in place of Dr. Osborne, since he cannot be here. But several patients expressed with NMO, spectrum disorder, how frustrating it was to seek care from anyone beyond their neurologist. Many times they get a bewildered look when they tell someone that they have neuromyelitis optica spectrum disorder. So they're interested in knowing, is the word being put out there to general healthcare practitioners? And also, how can they describe this to practitioners that they meet, and even just family members who don't know what it is?
Yeah, it's an important issue. Not long ago, certainly when I was in training, we did not realize that NMO existed separate from MS. We thought that maybe it was just a variation. And so it's only been in, let's say, the past 15 years that we even recognize that NMO is a different disorder. It has a different cause, and it has different pathophysiology. But even then, it's only been maybe 3 years that we've had FDA-approved treatment options for NMO, which have sort of taught us that it's very important for us to separate MS from NMO, because treatments for MS may not be helpful for NMO and vice versa. So really, the reason I think people are asking this question is because we're in a transition. We're in literally a point in time when we in the medical field are just learning about this distinction and spreading it to each other. And again, people who are not experts may not be as aware of this. So we are absolutely doing more to try to reach out to our own peers in terms of education, and also to get the word out into the community that symptoms like transverse myelitis or optic neuritis, or sometimes nausea or brainstem types of presentations, may represent something distinct from MS, which is NMO. So we have a lot more work to do, but absolutely, this is something that everyone on this call is focused on.
Thank you, Dr. Shin. Kim, we have a question for you. Again, there were lots of compliments about your talk. One comment was it was a great list of red flags for burnout, and they would love to have access to this list. And I just wanted you to be able to speak to patients about your newsletter and how helpful that tool can be.
Yeah, that's great. So one of the things that I've started in our clinic is a quarterly newsletter that we've put out 2 so far, and I think that they're chock full of information. So if you are in our constant contact list, so if you've got the constant contact for this training or this presentation, then you should be getting my newsletter. If by chance you are not, and you found this presentation a different way, feel free to contact the MS Center. You can ask for me, Kim Foster. You can ask your MS provider. They'll get you in contact with me, and I'm happy to put you on the list and also answer different questions. I don't know if there's a way for me to put my email or phone number in the chat, so if someone tells me, I'm happy to do it. But the MS newsletter is a really great way. The other thing is you can Google caregiver burnout. That's another one, and that has an extensive list as well. or the MS Society, National MS Society has a tab about caregivers and coping with MS, NMO, MOG, things like that. So that's another way to get information as well.
Thank you so much. And if, everyone who is on this is in our constant contact, because that's how you were invited. I think we have time maybe for one more question. This relates to Dr. Wilkins' talk, but I'm going to direct it to you, Dr. Tornatore. So if
It's
you...
about aging and cognition, I'm going to be pissed.
So is there a way to look at the MRI and tell if someone is going to have cognitive difficulties, one, and then two, if someone does have cognitive difficulties, are there different treatments you would consider?
Okay. Yes. So yes, Dr. Wilkins, talk really was terrific in describing, the cognitive issues that a lot of patients with MS have. And I think, it's important to kind of frame it in a way that might make a little bit more sense. We were sort of coming to the idea that in some ways, MS may be, for lack of a better word, accelerated aging when it comes to the brain, right? And so that it can lead to shrinkage and atrophy of the brain. And so normally, all of us, our brain shrinks at about 0.3% per year. That's all of us. After the age of 20, we're all on a downhill slide. With MS, if there's active inflammation, that can be as high as almost 1% per year, so almost 3 times as much. And when we look at the MRI, yes, we can see this. We may see that given the person's age, the amount of shrinkage or atrophy that we're seeing is out of proportion for that person's age. And when we look at that, we would say, oh boy, that portends that they may have cognitive issues earlier in life because the brain, again, for lack of a better word, looks like it's older than it should be, right? And so atrophy or shrinkage of the brain absolutely can correlate with cognitive symptoms in the future, but also in the present, right? Somebody who has, if we see that at an earlier age, if we did cognitive testing, we could probably pull out some things that they have. Maybe it doesn't impact them on a day-to-day basis, but it's something that's there. And we know that a large number of our MS medications do slow the progression of brain shrinkage, which in turn means that we can slow the progression or even prevent cognitive issues in patients. The key is to catch that early. Once we're kind of too far down the line, people are going to have cognitive issues. We may keep them from getting worse, but we may not be able to reverse them. So yes, the MRI, if we see atrophy on an MRI, that's an indication that this is somebody who may have cognitive problems in the future. And in some cases, people would say, well, if you see that happening and the person is on a particular disease-modifying therapy, that might be an indication to switch them to something else, because maybe you can slow that progress down. And I think there was another question that I saw in the Q&A that said, well, how is it that the MRI doesn't change all that much, but that I feel like I'm getting worse, right? That's a very, very typical scenario. Well, the reality is the MRI is probably changing, but it's so subtle that we can't see it. And it's the same thing with cognitive issues. The changes may be glacial, but over time, they may become evident. And then we see that correlation between the MRI. Treatment for cognitive issues are twofold. One is get at the root cause, get the MS quiet. That's absolutely rule number one. Whatever we can do to get any active inflammation down is absolutely critical. So getting on a disease-modifying therapy that is right for you, that fits, really makes a heck of a lot of sense. And then treating the cognitive problems, as Dr. Wilkins alluded to, there's a lot of reasons people have cognitive issues. And this gets tied into mood, fatigue, and cognition. Those three things, we actually just recently wrote a paper where we feel pretty strongly that those three things are tied together and you cannot tease them apart. and that people who have one generally tend to have all three. So having said that, what can we do to treat mood? Well, Kim just talked about a lot of non-medicinal approaches. Deb did dance. I'm a personal believer very much in physical activity and exercising and supplements and all these different things that we can do to basically kind of fight fatigue and by extension help improve our cognition. Having said all that, there are some people who really need to have their mood evaluated, whether it's anxiety, depression, obsessive compulsive behavior, mania, all of these things. You have to treat that. If it's bad enough that it's impacting somebody, there's no shame in having that treated. Clearly, there are concerns about using medications that people may have because of side effects, but you have to weigh the risk versus the balance. And then for fatigue, there are a number of things that we use for fatigue, including old drugs like amantadine, newer drugs like modafinil or armodafinil, which are both known as Provigil or Nuvigil. Sometimes people will actually use bona fide stimulants, things like methylphenidate, for people that really just can't function at all. In some cases, the studies aren't great, but there are drugs that we use for memory, for Alzheimer's, that some people say have some value in treating cognitive issues with MS. I think it's highly suspect how good those work. But there are medicinal approaches to treat fatigue, to treat the mood, and that indirectly will help cognition. But the bottom line is it's use it or lose it. Just like with our muscles, you've got to move all day. From a cognitive standpoint, it's use it or lose it. You've got to stay cognitively engaged, whatever it is that's your mojo, just do it, and it doesn't have to be, people say, oh, is it crossword puzzle? Is it Sudoku? Whatever, just do whatever that turns you on, just get engaged, go out there, just talk to people. That's the, whatever it is that turns you on, just do it. Just don't get totally isolated. That's a killer. So I'll stop there.
All right, well, that takes us to the bottom of the hour, and that's our program for this year. I know that we didn't get to every question, so I'm going to recommend that you reach out to your provider and remember the question, and next time you talk to your provider, go ahead and reach out. For my one patient who keeps texting, please call me. I will give you a call on Monday, I promise. So there have been many questions about how can we see these programs again, or how could we view them? These have all been recorded, and once we have these downloaded, we will provide them on the website. So any talk that you missed or another talk that you'd like to review, if you want to look at the list of red flags that Kim had presented, that is going to be available for you on our website. And we've said it many times, this program wouldn't have happened without the work of Bethany Schreiber, who just from really, it's a 365-day-a-year project for her, and she always makes it fantastic. But please fill out your evaluation form. So you will be getting that, and please give us feedback. Let us know if you like the program, what we could do better, maybe topics that you'd like to cover. As Dr. T mentioned, this year we focus a lot on clinical care, but I think alternate years we often have much more of a research focus, so we'll look for that in the future as well. The website, a lot of people have been asking about it. You can see it's neurology.georgetown.edu/MS Center, and that's where we keep all of our previous talks, as well as information about goings on at the MS Center. So thank you all for spending time with us. Thank you to my colleagues for spending their morning and for giving such awesome presentations. Again, thank you, Bethany. Thank you to Coalesce for putting together the website for us. And thank you to all of our sponsors for making this possible. Again, thank you so much, and we'll see you next year.